Roll call.
Good morning, members of the Joint Appropriations Committee. December 8th is the sixth day of agency hearings. Senator Driscoll.
Excused.
Senator French.
Here.
Senator Garou.
Here.
Senator Larson.
Here.
Representative Almand. Representative Angelos.
Here.
Representative Harrelson.
Here.
Representative Pendergraft.
Here.
Representative Sherwood.
Here.
Representative Smith.
Here.
Co-Chairman Bear.
Here.
Mr. Chairman, Senator Salazar.
Here.
Mr. Chairman, you have a quorum.
Thank you. Good. So what do we have up first, Mr. Richards?
Good morning. The first agency for your consideration is Agency 14. It's the Miners Hospital Board, and I believe the Executive Director, Angela O'Cray, is here to present with her team.
Come on up. Good morning. Good to have you. Director, I'll let you start, and good to have you here.
Good morning, thank you. Good morning, Chairman Salzar and members of the Joint Appropriations. My name is Angela Ockrey, and I'm the Executive Director for the Wyoming Miners Hospital Board. With your permission, I'd like to give a quick state of the agency. Okay. My team is made up, before I do that, introduce those that are with me. I have my chairwoman, Kathy Schmidt-Miller, and Barb Wallace from A&I Fiscal. My team is made up of 3 dedicated staff. We have 2 support specialists and myself, Executive Director. Together, we operate our main office out of Gillette, and our office, we have a satellite office out of Rock Springs. We have about 6,900 members across the state of Wyoming. Individuals who've worked in the mining industry qualify for these benefits if they have 10 years of mining experience and are a Wyoming resident. We provide financial assistance to those in the mining industry in the conditions of pulmonary, respiratory, hearing loss, cardiac, and musculoskeletal conditions due to labor in the mining industry. Each individual who is active and enrolled in the program can receive up to $5,000 a year in annual benefits, and every 5 years, $3,000 towards hearing aids. These benefits are meaningful and make a huge difference in individuals' lives as they've worked very hard to make Wyoming prosperous in the mining industry. With that, I have one exception request, and that is the TRP that's been discussed previously. I'm happy to answer any questions that you do have.
Okay. Any questions so far? Why don't you anything else? That's it?
We're short and sweet and to the point.
Okay. No questions? Any? Yeah. Yes, I'm sorry. Representative Sherwood.
Thank you, Mr. Chairman. Just wondering, big picture, in terms of the funding for miners, can you talk to me about your strategy in regards to the corpus, investing it, and what your goal is in terms of how much you project you will need in investment income over the next 5 years? Thank you.
Chairman, through you, Representative Sherwood, our corpus is very solid right now. The one thing that we do watch is we make sure that we keep in mind the number of individuals who are enrolled in the program, plus those who are potentially eligible in the next several years. And we manage the program through what we call a 3-2-2. So the first $3,000 in eligible claims we pay, and then what we call a donut hole deductible. So the individual is responsible for the next $2,000. And after that, we pay an additional $2,000. So the first 3 and the last 2 is what makes up that $5,000 difference, just so that the individual has some skin in the game also for the benefit.
Yes, Mr. Kochak.
Did you have a follow-up?
Oh, I'm sorry. Did you have a follow-up, Representative?
Thank you. So thank you, Mr. Chairman, and thank you for being with us this morning. I'm looking at the corpus balance. Is it 85 million, 89 million? Do you have an update on where that number is today? Thank you.
Thank you, through the chair. The corpus is currently $90,275,233.
Please.
Thank you, Mr. Chairman. Because you do have such a healthy corpus, I think that naturally creates questions about how else could those funds be leveraged, knowing that you can't touch the corpus, right? That's the point of an endowment model. But has there ever been conversation about expanding the definition of a minor or expanding who is eligible for these benefits?
Through the chair. There has been some discussion about potentially other individuals such as oil and gas, agriculture, or things like that. The way the statute's written, it's very clear on what a definition of a minor. And the one piece of that that's really important is to make sure that the individual is day in and day out at the mine and not rotating around and moving around. And as it's written, I'm not sure how you would make sure that the individuals in those other categories would qualify based on that information. Thank you.
Mr. Chairman.
Thank you, Mr. Co-Chair. Thank you for being here this morning. Director Okri, I have two questions, really. One is, Representative Sherwood brought up the eligible, but I'm curious if you can tell us a little bit about who's really making use of the fund. So what is the participation level? You've got 6,900 active miners registered. How many on an annual basis are using the program? And then when I'm looking at the accounts, I'm looking at the Miners Hospital income account, and it seems to be being depleted. And I'm curious about your anticipated expenditures from 2020 to 2028. They almost double. And what is causing that, if you could try to share that with us? Those are my two questions. Thank you.
Director?
Okay. First question, annually, we have about 56% of our individuals utilize their benefits. That being said, not everybody has medical conditions every single year, and not everybody utilizes the hearing aid benefit because they qualify every 5 years for the hearing aid benefit. So that kind of averages out, but it's about 56% that utilize the benefit. And I'm going to direct the other question to Barb for answer of that one.
Thank you, Chairman Salazar, Co-Chair Bear. We'll have to get back to you as to what's caused that increase in the expenditures from, you want to clarify, that was from the 23 to the 25, sir?
Please.
Thank you, Mr. Co-Chairman. Ms. Wallace, I'm just looking at on the expenditure of the unit 0101 in the 19 to 20 biennium was 5.7 million, and we're anticipating 9.8 in this next biennium. So nearly doubling that since the 1920 biennium, and just would like a little bit of an explanation as why that's anticipated to double. I mean, obviously, this biennium, it has doubled, almost doubled. And what's causing that increase on that fund? And what kind of plan you might have to address that? Because there's going to be a point in time when this fund is not going to be sustainable. So if you could give me that kind of information, and if you could get that to us in the next week, would that be possible?
Yes, sir.
Okay,
Thank you.
thank you.
Any other questions? No other questions? Okay, well, thank you for being here. Appreciate it.
Thank you.
Hanson, good morning. So members of the committee, we have the Department of Health for most of the day, for obvious reasons. So Director Johansson, good to have you here, and maybe you can introduce your staff and take it away.
Thank you, Mr. Chairman. Mr. Co-Chair, members of the committee, Stefan Johansson, I'm the Director for the Wyoming Department of Health. I appreciate the opportunity to introduce the staff I have with me this morning. Starting on my far right here, Franz Fuchs is our Deputy Director of the Department of Health. He has over 13 years, almost 13 years experience with the department. Eric McVicker to my right is our Chief Financial Officer, nearly 15 years with the department. Behind me, some of my senior staff, in case you have more detailed questions that I can't answer. Reagan Latham is the Senior Administrator of our Behavioral Health Division, nearly 20 years with the Department of Health. Jesse Springer, who some of you from the subcommittee spent a lot of time with over the interim, is our State Medicaid Agent and Senior Administrator for the Healthcare Financing Division. And Stephanie Sandoval, about 10 years with the Department of Health, is the Senior Administrator of our Public Health Division. Mr. Chairman, I'll also be joined by Jeff Clark from our Community Living section in the Aging Division, Elizabeth Forsland from our Home and Community-Based Services section, which oversees our developmental disability and long-term care waivers. And also from our Public Health Division, Dr. Alexia Harris, our State Health Officer, and Dr. Joseph Reed, who administers the Wyoming Public Health Laboratory. We didn't want to overwhelm the committee room with Department of Health staff, but thought, given some of the discussions over the interim, that I'd bring some of the experts with me today. Mr. Chairman, I wanted to start by thanking this committee for its work over the interim, and I mean that sincerely, not only on the topic of our developmental disabilities waivers, but in the establishment of the Joint Appropriations Subcommittee, and for Representative Pendergraft, Representative Sherwood, and Senator Larson for spending a lot of time with the Department of Health over the fall. I hope the feeling is mutual. We found the discussions very beneficial, difficult topics, but also the ability to spend some time diving into the details of the department's budget, how we manage performance, how we look for and address fraud, waste, and abuse. We found the dialogue very fruitful and hope some of that sentiment was shared this fall. And just diving into the details, Mr. Chairman, we provided a document to the committee, relatively short document, called the Wyoming Department of Health Budget Roadmap, should be in your committee materials. If it's okay, Mr. Chairman, I just wanted to spend a few minutes on that document because we've been producing it, or a similar version, for the past several years, mostly intended as a reference document and an at-a-glance summary, not only for this committee, but for legislators as you enter the session. It's really not intended to walk through in great detail every item of the department's budget or every exception request, but give our policymakers, our decision makers, a document that's a little bit easier to reference as you go into session and have serious and grave and tough decisions facing you as policymakers, that this is something you could quickly reference to get a glance at the department's budget, but also a reference document for our exception requests. That document on page 1 starts with what we call a full budget overview. Really just a few fun facts about the department, how the money is split out, where the bulk of the dollars go in the department's budget. But if you look at table 1, we tried to make this as useful as possible, but really looking at the department's budget by programmatic category. And this won't tie directly into the budget book, but as members of the subcommittee know, we find it useful in the Department of Health. We think policymakers and legislators might feel the same, to kind of summarize and distill some of our functional categories into more easily understandable areas. So what you see here is various budget or expenditures of the Department of Health broken into kind of some higher level categories. So you can see on the left-hand column there, we have Medicaid and CHIP services. Represents the bulk of, or a higher percentage of the Department of Health spending.
Thank you, Mr. Co-Chair. I'm just going to ask that you call out page numbers for the public and for the committee, just so we can stay on the same page and keep track. Sorry.
Absolutely. Thank you, Mr. Chairman, Co-Chairman Bear. So on page 1 of the summary document that we provided the committee, Table 1 on page 1 kind of shows those functional categories of the Department of Health's budget. And I'll just give you a few examples. Medicaid and CHIP medical services, walking through the different columns there on table 1, you can see State General Fund in the first financial column there, $206 million, with $422 million of federal funds, $55 million of other funds, for a total of $684.7 million. Then in the final columns there, we break out what percentage of the budget that functional category represents, starting with the percentage of the total State General Fund budget, the percentage of the total budget, and then in the final column there, you can see it adding up cumulatively. We've experimented with this table, members of the committee, over the years, just to show, again, a little bit more simplified version of where the Department of Health's money goes, but also to give a sense of the scale of what those different categories or spending areas represent in terms of the total budget. You've heard me say a lot that over 90% of the department's budget goes out the door in the form of reimbursements to providers, community organizations for services, or in the form of direct care provided to members of or residents of the state of Wyoming through our facilities or through our field offices around the state. And hopefully this table kind of shows, again, a little more detail of where that's broken out. On page 2, Mr. Chairman, of that summary document, and table 2 of that summary document, you can see the Department of Health positions. And we tried to break those out by location to give the committee a sense of where are the positions located through each division of the Department of Health, in Cheyenne, in our county field offices, in our state facilities, and then similar to table number 1 on the finances, the total and the percent by each division. I think the big takeaway here is that about 3/4 of the Department of Health's authorized positions are either in our direct care 24/7 state facilities or in our direct care public health and field offices around the state. Mr. Chairman, page 3, I won't go into all of the detail in the subsequent pages, but the next section is where we break down our exception requests. And as you've seen from our summary materials, this year the Department of Health is requesting $83.4 million in state general funds, an eye-popping $562 million in federal funds. We'll get into some of the detail on that, and $98 million in other funds, with a net negative 10 positions. So you will see some position eliminations that we'll get into during our page turn of the budget here in a few minutes. The governor out of that has recommended $76.3 million in state general funds, $556 million in federal funds, and $98 million in other funds. If you move to table 3, you can see our exception requests broken down by each division. Just to give you a glossary of the acronyms there, HCF is the Healthcare Financing Division. That's basically Medicaid and CHIP services. DO is Director's Office. PhD is Public Health Division. BHD is Behavioral Health Division. And AGD is the Aging Division. But I think, Mr. Chairman, what I'd like to focus on table 4 is very similar to the overall budget summary that we went over on page 1. Table 4 does something similar. Again, over the years with this committee and over the interim with the JAC subcommittee, we find it useful, at least at a summary level or an at-a-glance document like this, to break down the complicated large Department of Health budget in our requests into some functional categories. So table 4 does just that with our exception requests. And we've collapsed our budget request for the 27-28 biennium into 6 functional categories: mandatory requests, additional enrollment in programs, DD, or Developmental Disability Waiver System capacity, a category we're calling provider retention. This is basically reimbursement rates that you'll see in our budget request where we have concern about provider participation largely in the Medicaid program. And the last two categories, administrative capacity, which we'll get into throughout some of our requests related to various elements of the Department of Health, both requesting additional funds and in some cases, like with position eliminations or contract reductions, some reductions in those areas, but largely related to administrative areas of the Department of Health. And last but not least, a federal fund budget authority. We have a very unique year this year, given the opportunity from the Trump administration and Congress with the One Big Beautiful Bill Act and the Rural Health Transformation Program funding that's currently in process, and we can talk about those details later. But we are providing a placeholder here. We don't know what our ultimate award, if we get an award from the federal government, would be in that program. So in full transparency, we wanted to bring that request for spending authority should we be approved in that program, and should the state want to accept those funds. We've provided an estimate for the next biennium of what we believe the Rural Health Transformation Program might bring to the state of Wyoming. And in addition to that, we have a few other relatively large federal fund requests related to our supplemental payment programs in Medicaid, which do not require general funds. But again, we can talk about the detail there. For supplemental payment programs we have for primarily hospitals, physicians, and ground ambulance services.
I have a question, then I'll Representative Pendergraft. So with regard to the 501, the federal funds, can you talk to me for a minute about, do you foresee the state legislature having a part in how that is allocated and where it's allocated?
Mr. Chairman, thank you for that question. It's a good question. So yes, in some areas, no, or maybe no in other areas, and there's a few reasons for that. We want to make sure that we're making these decisions in conjunction with the legislature, which is why you see a request like the Rural Health Transformation Program funding here. The timing is an issue because this bill, Big Beautiful Bill Act, or HR 1, was passed in July. The guidance for this program, the application guidance for the Rural Health Transformation Program, came out in mid-September with a direction to all states to apply for the program by early November. We have done that. The law also requires the federal government through Centers for Medicare and Medicaid Services, or CMS, to make award decisions by the end of this year. So if we receive an award or a partial award or approval or whatever that might look like this month, we have a placeholder now. We anticipate coming back to this committee and to the legislature with updates on what the details look like with potential approval. And then there's a few areas, Mr. Chairman, to get more specific with your question, that were part of that application that may require legislative action this session or in subsequent session in 2027. There's a few parts of that application that the federal government and the Big Beautiful Bill Act called state policy action items that we have baked into our application. Things that the legislature has been considering, like waiver in the SNAP program for nutritious food, different licensure and scope of practice issues that the legislature may decide in the next interim to bring forward with legislation, things like practice acts for dental hygienists, et cetera. So there's a few areas where we think legislative engagement would be necessary. On the macro side, the reason we engaged in a lot of public feedback, provider feedback from September to October as part of the application development was to make sure that we had as many people at the table providing us feedback and not the executive branch designing an application in a vacuum. But again, the timing is a challenge because we know that we should see award decisions by the end of this calendar year with potential legislative interaction on things we need approval on or policymaker feedback on going into the session.
Let me, so will you come back to this committee to update us or to seek approval?
Mr. Chairman, I would say both in terms of updates of where we are. So let's fast forward from now until January, when you all are meeting again on budget hearings. There's a good chance that your director of the Department of Health may ask for time on the agenda of JAC if that can be supported, if we have that level of detail from the federal government on items we may need either approval on the finances or approval on some areas of content. But also, as I mentioned, this is a 5-year program. This goes from 2026 to 2031. And with certain elements of our application, we've really tried to be forward-thinking, future-focused on extending those benefits well beyond the 5-year funding period to avoid some of the pitfalls we've seen with other federal funds in the past, where you reach a fiscal cliff and you've funded all of these things and suddenly the fire hose shuts off and everybody's left wondering, what do we do now? So I don't see it as ending in terms of our legislative engagement this upcoming session, because this is a really, I think we're optimistic. This is a really good opportunity for Wyoming, not to just get our hands on additional federal funds and finance the same old things that we financed in the past. In fact, that's largely not allowable under this program. And so if, as we go into details about the program or should there be changes to that, Department of Health is more than happy not only to brief this committee and the legislature, but in those areas where I think we need policymaking, absolutely be asking not only for approval, but for input, feedback, and in some cases, action from the legislature.
Thank you, Mr. Chairman, and thank you, Director, for being here. Seems like we've almost become family. I'm looking at your 501 million and then the other funds, the 98 million, and just asking for a little bit of clarity there. My understanding is that the application, according with the one big beautiful bill and the rural health, was basically the 500 million over 5 years. And then that you also submitted a request for maybe a merit-based or an additional grant over and above that. So I would ask you to describe that. And then give us just a little bit of an idea of exactly what these other funds, 98 million, entail.
Mr. Chairman, Representative Pendergraft, thank you. And yes, it does feel like we've become family. And as the old saying goes, you can choose your friends, but not your family. And I bet that's felt both ways. But no, thank you for that question, Representative Pendergraft. So just to break down that 500 million that you see in this category on the summary document, three elements go into that. One is the Rural Health Transformation Program estimate, and that's about 340 million of what we put in as a placeholder. 98 million of those federal funds are in the supplemental payment programs that I mentioned. So these are programs that Wyoming legislature has authorized over the years. The federal government allows this in Medicaid, and it's basically a way to increase cost coverage with certain types of providers with Medicaid reimbursements without the legislature having to appropriate general funds for those reimbursement rates. The way it works, and in this case, we'll keep it specific to hospitals, physicians who work in hospitals, and ground ambulance, which is relatively new that the legislature authorized a few years ago. The way that works is we take those providers, let's say hospitals, we assess a fee or a tax on those providers. We collect that revenue from the providers. The federal government then matches that revenue that we collected from the providers, and then we redistribute it based on an approved federal formula back to those providers to, in a way, increase that cost coverage without changing the specific reimbursement rates on a specific service. Those programs over the past several years in Wyoming have grown, which is why you see the federal spending authority request in that 98 million. You'll see 98 million in federal funds and 98 million in other funds, which is that revenue collected from the providers. So it's a bit of a funny program. All states do versions of these supplemental payment, or what we call UPL, or upper payment limit programs. The big beautiful bill did address, and in some cases around the country, curtail these programs for a variety of reasons. We don't foresee any impacts in Wyoming for our supplemental payment programs because Wyoming has always been relatively conservative with those. So the new caps and limits, and in some cases financial withdrawals that the big beautiful bill imposed on supplemental payment programs will not impact Wyoming. And I'll give you an example. There are some states that do that exact same mechanism, but the cost coverage that they were targeting was not 100% of allowable Medicare costs, which is typically what we bounce off of in Medicaid. What's the upper payment limit? It's the 100% threshold of Medicare allowable costs. In some other states, you've seen 150%, 200% of the average commercial rate. And the federal government for years had been discussing, is this just unnecessarily increasing federal expenditures at the expense of the taxpayer, where the state does not have to appropriate funds? And you saw some of that action being taken in H.R. 1 in the Big Beautiful Bill. But again, in Wyoming, we've consistently and historically always been under those thresholds, and are under those thresholds that the Big Beautiful Bill set this past summer. So again, that's a big component of that $500 million that you see in the summary document. And a smaller component is really around B11 cleanup. And so as you've heard from Director Hibbert over the past several years, in the spirit of transparency, executive branch really trying to clean up these consistent B11s that we do for various, federal funds, federal grants. And the last component of that $500 million in federal funds, Representative Pendergraft, is in our aging services. Older Americans Act grants that we get from the federal government that essentially get deployed through senior centers for various programs. We've been doing B11s in that area for a little while, and this is essentially cleaning up that process to have that federal spending authority of funding that's already there, has been approved and appropriated at the federal level, and we thought it prudent and with budget office guidance to say, let's bring that to clean that up in the standard budget of funds that generally come in, that we don't have to do a B11 during the interim period. Representative Pendergraft, did that answer your question?
Thank you, Mr. Chairman. Yes, it does. I just want to very briefly drill down into that 340, because I keep hearing 100 million a year for 5 years. So that 340, is that the first 2 years? And then the other 140, that's the additional request, or the merit base?
Mr. Chairman, Representative Pendergraft, another really good question. Let me back up and just mention to the committee, this budget request was actually developed long before the federal guidance even came out. So this was the best estimate we had essentially at the end of August when we submitted this to the governor for consideration of what we thought might be coming in. To answer your question directly, yes, this estimate represents what we think would be the higher end of what the state of Wyoming would receive for the remainder of this biennium, so going to June 30th of next year, and through the 27-28 biennium. To summarize, because Representative Pendergraft, I know we discussed this at length in the subcommittee, the way the federal government and the Big Beautiful Bill allocated the rural health transformation funding is in 2 tranches. And it's $50 billion that Congress appropriated, half of which, $25 billion, is allocated to all states who have an approved application. And we're assuming, for the sake of estimating, that all states will have some level of an approved application. That floor, that sort of equitable funding, so to speak, that the federal government will allocate, that floor is $100 million per year for 5 years. That's where that floor came from that we've been discussing. The second tranche of funding for rural health transformation is what they call the workload funding, what I like to call merit-based or competitive. That's the second half of that rural health transformation program. And that's related to the quality of a state's application, the initiatives they've chose, how the federal government and their panels will score a state's application on the ability for them to achieve the goals or the initiatives that they set out in the application, and frankly, just the merit or quality of the application itself. So that's the unknown that we don't know. I believe we will have an approved application, and we will be at the very least at that floor. So over a 5-year period of a floor of $500 million, I think based on the quality of the application we submitted, the immense amount of public feedback we solicited over a 6-week period from towns across Wyoming, from online engagement, online survey, provider engagement, and just the general quality of, in my opinion, of the initiatives and the true sustainable transformations that we've proposed, well beyond a 5-year federal grant period. I think Wyoming could stand to see a good chunk of that second tranche of funding well above that floor.
Ms. Kuchar.
Thank you, Mr. Chairman. welcome, Mr. Hanson. I appreciate your being here, Director, and got a lot of work to do today to get through all this, but I appreciate your explanation there. My question is about the 98 million in matching funds from the other fund category. In this supplemental or in this program, are these providers able to invest with in-kind services, or is it a cash amount that's going into that fund and then being sent, matched with the federal fund? So are they actually putting up dollars into this fund for the other funds authorization that we're contemplating here?
Mr. Chairman, Co-Chairman Bear, the simple answer to your question is these are cash contributions. These are payments or essentially assessments that those providers must make financially, not in where we see in other areas of the department. Elder services, for example, with federal grants, you can have some in-kind matches of we're delivering this service, therefore it will count towards that. In these Medicaid supplemental payment programs, generally speaking, and our state Medicaid agent, Mr. Springer, can correct me if I'm wrong, these are all financial. You cannot use in-kind services to generate that revenue.
Thank you for that response. On the application, you felt that it was going to be approved. Are there any particular parts of it that you are concerned about that maybe, and can the federal government just say, we don't like this portion, we'd like you to exclude that?
Mr. Chairman, Co-Chairman Bear, it's a really good question, and I wish I had a firm and final answer for you. We're essentially in negotiation period with the federal government now. In fact, just this morning received a few questions on the budgeting in that application from CMS that we'll respond to later this week. I don't believe that our application will, because there's a potential component of it that the federal government deems not allowable, that where they would say Wyoming's application is therefore denied. I think it will be a back and forth the remainder of this month to say we have some concerns about this particular spending category or area, give us some more detail. And if that were a decision the federal government made to say that particular initiative, that particular cost allocation is not allowable, I think there would be a dialogue to either modify or remove that particular area versus denying the application outright. But time will tell, literally over the next 2 to 3 weeks, to see where the federal government comes down on some of those areas. So again, timing is tough here because our application has been in the federal government's hands for about a month now. And aside from acknowledging receipt of the application, today is the first we've heard of starting that engagement in negotiations.
I have several questions about the application and about your negotiations that are ongoing. I'm going to ask you, is this a good time to ask those, or should we wait until a later part of your presentation?
Mr. Chairman, Co-Chairman Bear, I think now would be a great time, given that it is such a macro item in what we've submitted to the federal government. It's not very complicated in terms of the budget request here because it is a placeholder federal spending authority request. So I think now is a perfect time to go into those details.
Mr. Co-Chair. Okay, we'll start this line of questioning then. And I asked the rest of the committee to join in. But as I look at the governor's narrative about the budget, he mentions this on page 4, this particular issue. He talks about there being a healthcare benefit plan, an innovative healthcare, but basic healthcare plan. And I find it in the application, I believe, on page 30. It says the establishment of the Bear Care Public Major Medical Plan. Before I get into the questions, the first thing I'd like to ask is, how did we come up with that name?
Mr. Chairman, Co-Chairman Bear, as coincidental as it seems, we did not name it after our fine chairman of Appropriations. However, it is somewhat of an eye-catching name, but it really goes back to looking at a basic health plan that funds quote unquote the bare necessities. Also, given Wyoming's deeply forested areas and bear population, we thought it somewhat of a fun name, catchy name to call it that, but it really does it kind of harkens back to what some people knew health insurance to be in previous decades of, if you think of your car insurance paying for major mechanical issues, crashes or wrecks that you get in, but not paying for oil changes or your basic maintenance that really comes out of pocket. In a similar vein, and I'll go into a bit more detail if that's okay, Mr. Chairman, this offers not a replacement, but an alternative to what we've seen on the Affordable Care Act or Obamacare marketplace. And at this point in time, members of the committee, this is a conceptual idea that we are proposing to CMS to see if this would be allowable under this program for the state of Wyoming to essentially experiment with. And we know, you all know, that changes might occur, significant changes might occur to the ACA marketplace that's been in the national news with the expiration of some enhanced subsidies for that health insurance that were put into place in the pandemic era around 2020. Whether or not Congress makes a decision to extend those subsidies more broadly in the ACA marketplace, we do foresee changes to the ACA marketplace always being a potential. In addition, Wyoming has seen this, I think the country has seen this around the marketplace. The cost of that insurance has continued to go up and up. And when questions arise about those federal subsidies for that insurance, or Congress's willingness or ability to fund those subsidies, you see consumer concern around how much is my health insurance going to cost as an individual. Secondly, and this is something that we wanted to use this opportunity to at least get the policy discussion out there with the federal government and within our state. I've been with this agency for the better part of 13 years and testifying a lot at Joint Labor Health, this committee on various health policy items. You see a lot of the same type of industry associations, folks showing up to testify on health policy issues consistently year over year, with the exception of one group, and that's small businesses. And we know small businesses in Wyoming, those with under 50 employees, are a significant driver of economic development in the state. But very rarely do you hear advocacy or policymaking around their healthcare costs and health insurance costs. And I'll kind of give you an example here. If I'm a small business owner in Wyoming and I have 10 employees, and you want to offer as much in terms of salary and benefits to your employees as possible, but you're faced with a pretty stark decision. You can provide health insurance either through an insurance carrier or self-insuring or whatever that might be. And because of our size in Wyoming and because of the cost of healthcare, generally speaking, your health insurance costs as a business owner go up and up and up every year. Your second choice, or your alternate choice as a small business owner, is you don't provide those benefits. And there's nothing federally that requires you to at that size. And then you struggle to recruit employees because, let's face it, employees look for those types of both salary but also health insurance and retirement benefits, et cetera. We believe that this Bear Care idea could offer a lower cost alternative not only to individuals, but potentially small businesses, in saying the state will set up a plan with this opportunity we have to cover the basic catastrophic type care that folks might encounter. Things like a health condition that comes from a car accident, a cancer diagnosis that was unexpected, and only be covering those major medical expenses that result from an emergency department or an inpatient admission, without covering the broad array of services that you see in Obamacare plans, what we call the 10 essential health benefits that are a driver of that cost. And so, Mr. Chairman, Mr. Co-Chair, I know that's a long-winded explanation of the program, but that's the basic idea.
Thank you, Mr. Co-Chair. And if I may just keep this line of questioning going, if that's all right with you. Okay, thank you. Lot to unpack there, and I'll start with the name. Without objection, I'm going to call it Gordon Care. I think that's just as catchy. But it kind of establishes my concerns about this. First of all, on the application process, I don't think we're supposed to create programs that can't be sustained. So I want to know, how are we going to sustain this program? It is catastrophic, and it does create another option outside of Obamacare. And I agree with you, the expenditures in healthcare are greatly affected by the 10 items that are in Obamacare. But how did we get here? We got here because, the government itself put controls on wages at one point. The private sector said, well, let's use this benefit to differentiate between jobs and opportunities. And then now we have, an industry that is expecting these 10 items. I've never expected insurance to pay for that. It's much like your suggestion or your example of maintenance versus an accident on your vehicle. But even within vehicle insurance, we have the option of taking just liability only, which is similar to what this is, or comprehensive. So my question to you, first of all, is how is this government policy established by the state of Wyoming going to be any better in service provided or any better at keeping the costs down than those catastrophic programs that are already out there, such as MediShare and those types of programs? And you mentioned that businesses, you don't hear them talked about in the meetings that you're at. I'd like to know if small businesses have been clamoring to you or to anybody to say, we need this. And the reason I ask that, we heard testimony from A&I earlier that they struggle to keep electricians working for us in the trades. And one of the ways that they've kept one of their particular employees is the fact that we have a great benefit package with the state. But that was one older gentleman. This is specifically targeted, even in the application, it talks about younger people. And it hasn't worked for A&I to recruit younger people. I've owned small businesses and, we didn't have insurance. We toyed with the idea of things like supplemental insurance from companies like Aflac. But generally speaking, insurance has become so expensive that small businesses can't participate in that. And so they have to compete on a different level and in a different way. And I just don't see small businesses clamoring for an insurance program to be competitive in their marketplace. So I'd love to hear what you're hearing from small businesses, but I'd also like to know how this application can fit within the federal government guidelines that you're negotiating right now, and create a system that's going to have to be sustained for a long time. My concern is that we give them a hand up with this or hand out, depending on where your perspective is, and then the federal funding goes away, and then we're going to be either on the hook as a state for it, or we're going to take that hand away, and that could be worse than had we not ever started. Those are my thoughts and questions.
Mr. Chairman, Co-Chairman Barrow, take them in reverse order if that's okay, because the macro point is both what you began with and ended with. And it's a great question, because providing insurance, even catastrophic insurance, can expose the state to a lot of risk in terms of major expenses. We've designed this plan to essentially be self-funding, with the exception of some seed funding from those federal funds that could set up that pool to be able to cover some higher cost expenditures in that first plan year or two. So that's where we would offer this both at the individual level and the small business level, essentially at cost. So there would be a contribution from the folks participating. But the basic point, because I agree with you 100%, the basic point is that this isn't really offered right now to the extent that we are proposing, because small businesses, to use your second example, are faced with that decision of funding something on their own or providing nothing. This would allow, in our view, a way to cover something, and essentially have your employees be covered for their major medical expenses versus having to have Cadillac plans on the health insurance side. So we anticipate this to be essentially self-funding without setting the state up for expenditures after the 5-year grant period. One of the primary ways in this particular area of the application, and a few others, that we have proposed to the federal government to do that is essentially to not spend all of our award in this 5-year period, but instead invest in what we're calling the Rural Health Transformation Perpetuity. Essentially an account that's set up that is inviolate, irrevocable, and non-fungible in the categories that we've proposed using the perpetuity. That's both in bear care, as well as some of the items you see around the Critical Access Hospital Incentive Program that we've proposed, and our workforce development, essentially to offer education awards to physicians, nurses, emergency medical technicians, a variety of workforce there. We're proposing to spend less in the short term because the state of Wyoming could use the perpetuity to stretch these benefits and these system transformations beyond the 5-year funding period. To your point, Co-Chairman Bear, we don't know if the federal government will allow us to do it in the way that we've proposed, but I'm optimistic that we'll have a good negotiation there so that we can stretch those benefits out beyond 2031 and not reach the same kind of fiscal cliff that we've seen before, where you set up a program and suddenly it goes away, or this committee in the legislature is faced with a decision 5 years from now, do we keep this going? We've really tried to avoid that as much as we can in this application, and part of how we do that is through that perpetuity financing mechanism that we've proposed to the federal government. And setting up the initial reserves of the Bear Care Health Plan is part of that financing mechanism. If it's okay, Mr. Chairman, I'll ask our Deputy Director, Mr. Fuchs, to weigh in with any additional details, as many of us were heavily involved in the design development here. But Franz, anything that I missed that you'd like to add?
Mr. Chairman, members of the committee, Franz Fuchs, Deputy Director, Department of Health. Co-Chairman Bear, I just wanted to touch on a couple issues regarding to cost. The goal of this was really focused on affordability. And so we are looking at cost control in several areas. One of those is limiting the plan benefits significantly. So that is really, again, focusing on those emergency-only type benefits. You're not paying for office visits, you're not paying for drugs, you're not paying for a bunch of, this is probably maybe 30 to 50% of the healthcare spending would kind of be in this emergent category. The second component is you're basically taking the insurance and you're covering just what we call non-shoppable services. So this is stuff you really can't shop around for. You get hit by a bus or attacked by a bear, that's not something you really have the wherewithal to choose where you're gonna go. But it exposes everything else to that. So the idea is if you have this, you can go and say, hey, I want to go buy direct primary care, or I want to pay cash for this, or I want to pay cash for that. It exposes a lot more of healthcare spending to cash-based and thus market forces. So it has the potential, at least in the small scale, to, depending on enrollment, to try to use that lever to lower healthcare costs for their members. And then finally, we really want to control administrative expenses. And I think that's the main differentiator between what this plan would be and, say, a health sharing ministry. In those cases, data is kind of hard to find, but Colorado did require some reporting from these entities. And the average amount of what is collected from the members that actually goes to medical expenses varies all over the map, but it's somewhere around 40 to 50%. This plan would likely try to have a medical loss ratio, is what it's called, of the funds going to medical expenses, of 95% or higher. And so we really want to lower administrative costs and through those kind of three aspects, make things as affordable as possible. So the premium charge for folks is a lot lower than they'd expect from the exchange. And that really facilitates that individual buy-in and that small employer buy-in at cost. There's no subsidy here. This is purely cost-based. The premium charge would be the full cost plus the administrative load. And so by minimizing those costs, we can offer a more affordable alternative in that sense.
Thank you for that. I'm struggling with how we should go into, the free market. And I know it's not a great free market, but how we should go in here and compete with those very companies that we're talking about, whether their overhead is greater than ours would be or not. We're getting into a business that, frankly, the government created the problem in the first place based on what I said earlier. And so I'm not inclined to want to compete in the private sector. I don't think it's the proper role of government to do so. But back on the expenditure side of things, I think you created a simplified way, just 150% of Medicaid allowables, but have you guys thought about doing this from the other side? I think we do have a responsibility to try to help the infrastructure of healthcare within the state. We do that by having some of our own hospitals. But one of the things that's in this plan is to pay for all of those unpaid expenditures that Wyoming citizens have left at hospitals. But what if that were what you created a perpetuity fund for, so that we could keep our hospitals viable for years into the future, knowing that they have those expenditures, which some counties, step up and help cover, some don't. And those that don't are the ones that really become the places that don't have those facilities available to them. So has there been an idea to do this from the shoring up of the infrastructure of our healthcare perspective, rather than getting into the free market and providing another product, which frankly, if you did it well, which I would expect you to do it well, you're still government and you're limited by, all those things that you have to come here to talk to us about, compared to the private sector that can be nimble and can be competitive and look for other ways to be competitive. Otherwise, they just don't exist.
Mr. Chairman, Co-Chairman Bear, it's another good line of questioning, and I'll answer in a few ways. So we did looking at uncompensated care and long-term liabilities, for example, of hospitals, small rural hospitals around Wyoming, as an initial idea within this application. We're less optimistic, and in fact, a lot of the guidance from the federal government, when it came specifically just to fixing or correcting balance sheets, will likely not be allowable. Debt forgiveness, uncompensated care as a one-time, sweep to say we're going to shore up the finances of providers or hospitals that have seen large amounts of uncompensated care or could see it in the future, might not be an expenditure category that the federal government would allow with these funds. So the natural question is, why wouldn't they allow that? And I think if you listen to what CMS Administrator Oz or the administration has said about this program and issued in guidance, it's that they're really wanting through this program sustainable and transformational change in the service delivery and the system itself of how healthcare is delivered in rural areas. And I think that the spirit of that is well taken here. So what we've tried to design in here, and we'll use Bear Care and our hospital incentive programs as two examples, is by nature of having some of these or some of these finances coming to help offset uncompensated care, which Bear Care would do. If you have folks who elected not to have marketplace coverage and then had an event or a need to go to the emergency department or hospital, then the hospital is faced with trying to squeeze that blood out of a turnip for private pay, or just adding to the uncompensated care on their balance sheet. This plan would cover something, so it would both be a benefit to the individual and also to the provider to have some sort of revenue collection based on the episode of care that they provided. Secondly, Mr. Chairman, in our critical access hospital incentive program that you see in the application, again, I think simply it would be much easier for us to forgive debt, address balance sheet issues of uncompensated care. But the federal government has pushed, and in fact put in the guidance, they're not going to allow that to happen unless you see some sustainable business model changes in the healthcare system. And we've proposed several areas where we think that could happen to shore up the availability of OB services, to sustain our rural and frontier EMS agencies that struggle financially to collect enough revenue to even pay for the cost of having an ambulance in a rural area. We've proposed an incentive program that gets some business model changes in the healthcare system, which we can go into some of those details where we see that low-hanging fruit. And by nature of that, then provide the investments of either a perpetual payment for that system transformation, or in the case of Bear Care, to have some access to financing of what would be uncompensated care. So at a high level, Mr. Chairman, I think that's the main answer to your question of why wouldn't we just do this on the, be very simple, low admin. I think that's true. We don't know, and in fact, we didn't think that something like that would be allowed just to forgive, long-term liabilities or uncompensated care. And I think it goes without saying, there's also a fair amount of moral hazard there in an investment like that, where level of investment like this that the state would be facilitating, I think we do want some of those business model changes, long-term sustainable changes to improve the health system in rural and frontier Wyoming. And that's really where the federal government has been pushing us with this program.
Please.
So a couple of things there. Sustainable, I think what I've proposed would, if you use the perpetual funding model that you're suggesting for the health plan, it could be sustainable. And the scriptures say we're always going to have poor. And so we're always going to have this problem. But one of the things you pointed out is that a lot of the healthcare industry is out of our control. And it's on a trajectory for increased costs for perpetuity. It's going to get unsustainable, and God forbid, we're going to end up with a single payer program, which will be very detrimental to the American way of life. But I feel like this particular part of the application is kind of going down the same path as Romney Care did in Massachusetts, as Obamacare did. And I know you're trying to constrain it to catastrophic only, which is a novel idea, but it is still a government-provided program, and the state of Wyoming can't control what these costs are going to be. So the sustainability, I don't see how an invested fund, endowment fund for perpetuity or whatever can keep up with the ever-increasing costs of healthcare. And that's why I think it really should be left to the private sector, who can negotiate with individuals. You're going to have a set price for your premium. You're hoping that it will bring people to the table because you're offering something that they can't get elsewhere. I think you're competing with the private sector to do that, but that's what you're trying to do, is provide a product that's not out there and get young people into the pool, if you will, and therefore help hospitals. I think you need to work on it from the infrastructure side of things and not get into the private market if you can. So I've made that suggestion. I hope you'll take it very seriously. On the way I see Gordon Care being a problem is really this delving into the free market and the unsustainability. I think that the federal government in this application process, and you'll have to tell me based on your negotiations if this is true, if you show them that you're going to provide a sustainability thing, and it actually applies to the rural healthcare via hospitals and clinics in the state of Wyoming, that infrastructure that I mentioned, if you're going to do that, can you do that by making those hospitals, that infrastructure, sustainable? Will the federal government say, yeah, that's a plan, and that's going down the right direction? And then your request to do something kind of outside of their purview, which is this sustainability fund, this fund for perpetuity, this endowment, it seems to me like it would be more in line with what the chief executive of the country has said, that he's tried to repeal Obamacare. He doesn't want the government in the business of insurance. And so with that, I just will leave that suggestion out there for you and hope that you'll take it seriously, especially if you run into negotiation issues on creating a fund for perpetuity.
Mr. Chairman, Co-Chairman Bear, just to respond very briefly, first of all, I think we're saying similar things. Now, obviously, maybe some disagreements policy-wise on the details, but if you look into the application on where we've allocated most or proposed to allocate most of these funds, it's in areas that are in line with exactly what you're saying, to invest long-term in, for example, critical access hospitals and rural and frontier EMS agencies, where that revenue, if we see the type of business model and system changes that we've proposed, things that will lower their administrative cost, increase their revenue collection, get on the path to a more sustainable financial model through better reimbursements outside of the state, then that revenue would come in predictably over the course of the next 20, 40, 50 years through this perpetuity financing. So maybe with some different words, I think we're saying the same thing. And if you look at our allocation in the proposal, around half of our total award, and we don't know what that award will be, but we've allocated or proposed allocating about half of our total award to just that, infrastructure payments, to where what the state gets, what the consumers and the residents of Wyoming get, is more sustainable access to EMS services OB care, emergency department, some of the basics that we heard in our public meetings, which really made me proud to be in Wyoming. We did these public meetings, stakeholder engagement, et cetera, and we did not hear back a wish list of all of the expensive short-term things that every community wanted. We heard a resounding chorus on, we'd like access to, in our critical access hospital to make sure the emergency department is there and sustainable. Reasonable regional access to OB and maternity care somewhere nearby. Reasonable access to primary care somewhere nearby, and an ambulance that shows up relatively quickly when you call 911. Those things that we heard, we really designed the application around, and I think if you look at our cost allocation, even though some of the mechanisms might look a little bit different because we're having to fit this into federal parameters in the guidance that they issued, are absolutely in line with some of the concepts you just mentioned. Again, maybe with some few exceptions where we might disagree on smaller directions, but that long-term sustainable investment in the infrastructure of those basics is where half of our award is proposed to be allocated and then funded conservatively, as opposed to hundreds or hundreds of millions of dollars every year for 5 years. To scale that back, fund the basics, and stretch that out for those infrastructure payments and changes over a long period of time.
Okay, Mr. Minority Leader.
Thank you, Mr. Chairman. Good morning.
Morning.
I will refrain from speaking for the administration because it seems like that's being taken care of very well on other speakers. So I'll just ask a question about, it sounds like from what I'm hearing from this, and just correct me where I'm wrong, what you're trying to do with this allocation as far as the small business, and I'm a small business person, so I'm kind of keen on this. What you're trying to do isn't trying to provide a social, that big of a social net. You're just trying to give a hand up to help small businesses be able to handle a problem that I have to face every single day. In my business, I think we're paying, I think, we pay $7,000-8,000 a month per employee for insurance. Now, I'm in a restaurant. My employees have like a $10,000 deductible. None of them have $10,000. I'm self-insuring for the 10. Every day I'm rolling dice that more people won't go to the hospital than work. And so what I see this as a net on catastrophic care that might make it so I can afford to pay for the rest of the care a little bit less, then I can pass those savings on to I take care of my employees after a year. I pay the insurance, and like I say, I'm self-insuring, but a lot of businesses can't afford that. A lot of businesses in the rest of the state of Wyoming can't get there. So what you're trying to do is kind of bridge that gap just that much. Is that what you're trying to do?
Mr. Chairman, Senator Brew, I think that's a fair characterization as an option. Again, at the conceptual phase here with this type of plan, we're looking to provide those options that either are not available in the market today, both for individuals and small businesses, or that frankly don't have those guarantees on costs that would be covered down the line. But to your point, and in some of the feedback we received publicly, and frankly, some of the small businesses that I've chatted with, both this year and in previous years, that is something where an option like this becomes attractive to certain business owners. To say, I would love to provide this comprehensive package of benefits, but it becomes unsustainable on the cost side. If that catastrophic or large medical expense were somehow taken care of at a reasonable cost to the employer, then yes, it can open up options for different types of benefit packages that the business could offer.
If I can follow up?
Please.
And while there may not, and I don't know about the clamor, like I say, but here's what I do know. I got a hunch in the next 30 days, if the increases in the ACA kick in the way they're going to kick in, I got a hunch you may hear some more clamoring, but that's just a guess. But the question I had is about this idea of either funding, putting in a perpetual fund to have the deficit in our hospital payers and non-payers, which, if I heard you correctly in your testimony, you're getting guidance from that said administration that that's not what they're looking for. To me, I would heartily agree that subsidizing failure in perpetuity is not a good idea. But to say that partially, that be a part of the quotient as we're trying to navigate through these waters, however we do it, would possibly be acceptable. That, you know, there might be a smaller portion of that where if you come with the whole, that's the whole show, that's what we're trying to do, not so much. But if it comes as a piece, like with the other piece to help on the catastrophic side, that might curry favor. So we might get a 2-for-1.
Mr. Chairman.
To a point.
Mr. Chairman, Senator Grew, I think that's accurate. I think the balance between true transformation and change in service delivery of what the federal government's looking for, combined with a unique and creative financing proposal that we believe, I believe, fits Wyoming, with the experience we've had with fiscal cliffs of serendipitous federal funds that come down, we're trying to avoid that. But simply saying we're going to allocate these payments or these infrastructure investments with no sustainable change from the service delivery system, from the providers, I think would be a non-starter with the federal government, which is why you see the balance that we've designed into this plan.
One last follow-up. So, and just to make sure I heard it correctly, that by doing this in this 5-year window where this funding is kind of residing right now, one of two things probably happen. Either we're going to solve this problem, and I have no doubt that the current administration will probably be able to do that. But just in case it doesn't, we might be better off trying it this way and then seeing what comes from that to see if we can't even solve it on our own. Once again, trying to figure out ways that our local small business people, which are in the vast majority in this state, be able to do things that can raise the wages of their employees and make sure that their lives are better is the key to what you're trying to do. Would you agree with that?
Mr. Chairman, Senator Guru, I would not have any disagreement with that. Again, the devil's in the details on what ultimately may be approved by the federal government, and I think before we brief this committee or the legislature again on those results, there could be some technical or even broader changes to this proposal. But I will say on record here that I believe Wyoming put forward an innovative and creative application for the use of these funds that really prioritized what we heard from the people in Wyoming through the engagement we did, and frankly, was not surprising that throughout the rural and frontier areas of our state, it really was around the basics as opposed to the wish list, and that's what we've tried to design here.
One more follow-up. And so, just one last one, sorry, I just want to talk about that. You had these hearings around the state, and I'm sorry, I was down talking to another group downstairs, but I'd say you had these all over the state, and this was one of the key drivers that I heard it referred to as something else, but from what I heard and from what I saw from the report I read, that it should be called Wyoming Care, that that's what the Wyoming Care, what people in Wyoming want.
Mr. Chairman, Senator Guru, I think that's fair. In fact, we can quantify this. We received about 1,400 responses to the survey after we conducted about 11 or 12 public town hall meetings. And cost of health insurance was one of the top, I believe it was in the top 5. Number 2, thank you, Franz. Both, I think, driven by the potential fear of changes that are coming in the marketplace, but also just in general. I've been here in Wyoming long enough to see healthcare costs and health insurance costs go up, and a lot of that on the individual market has been, frankly, financed by the federal government through the Obamacare plans. What comes with that is 10 essential health benefits, a larger type of coverage, and so we're proposing something different to provide not a replacement, but options for not only individuals, but for small businesses. And I think seeing that, cost of health insurance ranking number 2 in the public feedback we received is pretty telling.
Thank you, Mr. Chairman.
We have a long road today, but this is an important issue, and I want to give the committee the ability to ask questions on this point. Representative Alleman.
Thank you, Mr. Chairman. Thank you, Director, and thank all your staff for being here. I hope you brought lunch. I'm very concerned. If we do Gordon Care and we do it wrong, government funds come and go. We don't know what we got in the future, what we have coming. Is this going to 3, 5, 10 years down the road push us into an income tax to pay for this? Because we cannot, once we initiate a program, it's very hard to wean the people back off of it. You can't do it. Is this going to drive us into an income tax?
Mr. Chairman, Representative Alamand, my answer would be unequivocally no. And I think if you look at the proposals within our rural health transformation application, that sentiment that we not only heard from the public, but that we feel in the executive branch, and I know it's shared here in the legislative branch, is exactly why we designed more conservative approaches for the use of these federal funds to not set up either programs, provider payments, reimbursements that are only specific to this 5-year period. It really is, with our infrastructure for EMS and hospitals, even with our workforce development, and this catastrophic health benefit that we're talking about now, the idea is to use a financing mechanism that avoids that fiscal cliff 5 years from now, where this body in the legislature is not faced with that decision. Should we keep this program going that Johansson came 5 years ago and proposed, said it would be the best thing since sliced bread, and now the funding's gone? And so forgive me, Representative Alamand, for coming off so bluntly, but we took that very seriously, and having experience with other federal funds, large grant programs, where not only the executive branch, but this branch was facing those same decisions, we've designed these programs specifically around, to get around that and to avoid those fiscal cliffs. And so much to the ire of some of the stakeholders that we did engage with, who would like nothing more than to have 5 years of incredible money flowing into their coffers or balance sheets, we know there's moral hazard there, and there's also financial hazard for the state. And so scaling that back, getting true system change in hospitals and EMS providers, which would benefit the residents of Wyoming, we then scale back those payments, those infrastructure investments, so that we can stretch them over long periods of time. And we think that perpetuity is the way to do that. Representative Alamand, time will tell, but time will be short because we anticipate negotiating with the federal government this month to see what may be allowable and not allowable. But your point is very well taken, and that was an extremely serious concern as we saw the guidance come out, as we saw the potential volume of funds. This is a big deal for Wyoming. This level of funding, even if we were just at the floor, $100 million a year over 5 years, $500 million is a significant investment of taxpayer dollars from Congress into Wyoming. Secondly, many other states, we talked about provider tax and supplemental payments before, where frankly other states have abused those programs, federal programs. Wyoming has not. The Big Beautiful Bill Act, in terms of federal funding reductions, various penalties, frankly does not impact the Department of Health and Wyoming Medicaid to the extent that it is in other states, where what they're dealing with is, yes, they might get rural health transformation dollars, but it's really offsetting major federal fund reductions that they're seeing in other parts of their enterprise from the Big Beautiful Bill, where in Wyoming, we view this mostly as upside. And so it's a huge opportunity, and we took it really seriously to design something that doesn't just get our hands on as much money as possible, make spending decisions without that, the future in mind, long after I'm gone, where this body would be considering the fiscal cliff that we put them in to face these massive expenditures. So a little bit of a soliloquy there, Representative Alamand, I apologize, but I think if you dig into the details of what's in our application, you'll see that spirit in many of those proposals of trying to invest this as conservatively as possible, but with the future in mind, and really looking at 25, 50 years of benefit and system change here versus a 5-year opportunity to fund pet projects of the state or the Department of Health.
Follow-up?
Thank you, Mr. Chairman. Thank you, sir. I also take this very seriously. And I am very concerned because of the fickleness of our government, that one year it will give us money, the next year it won't. In fact, in the Agriculture Department, they're taking away 5 federal employees this year. So are they going to just take away this money and push us into a income tax because we were not wise enough to steer away from a Gordon program? Gordon Care scares me. And I think there's other ways around this that we need to just slow down and kind of look at things over and just be very careful of what we do so we do not have an income in the near future. Thank you.
Mr. Chairman, Representative Alaman, your point and comment is well taken. Specifically and technically on whether the federal government could change the rules of the game here, that's always possible. Since this was passed, the Big Beautiful Bill Act, it would take an act of Congress to change it. And the investment from the Big Beautiful Bill in rural health transformation program is there. I can't guarantee that Congress wouldn't come and defund it, but we've tried to design these programs where the state of Wyoming would not participate, would not implement, would not continue to fund these areas should this opportunity go away.
So Director, I want to get to Representative Angelos and then Representative Pendergraft, but I think you're hearing that the committee would like additional information from your department on how this is going to play out so that in 5 years, 6 years, we're not holding the financial bag. I think that's something that you'll need to put together.
Mr. Chairman, totally fair.
Okay. Representative Angelos?
Thank you, Mr. Chairman. Thank you, Director. So question for you, and I have a couple questions. And they don't have to be long explanations, but I want to make sure that the public understands this. I'm a small business owner. I take part in a medical sharing. That's how we pay for our health insurance. So my question is, were you in communication with any other states or any other states creating something like this? And where did this idea come from?
Mr. Chairman, Representative Angelos, I'll try to not be long-winded here. Yes, have been in discussions with other states about this program, but I'll caveat that by saying this was a relatively rapid pace for when the federal government put the guidance out to all states in September and required application submission, I believe, by the 5th of November. So I'm part of a network of about 35 health directors around the state, and we met either weekly or every other week to kind of discuss where federal guidance was going with this program. In some cases where states were potentially looking to invest or allocate their funds. So had a decent sense of what was coming out from other states. I'm not aware of any other state that made a proposal specific like this with a public health benefit around catastrophic medical expenditures. Wyoming is innovating somewhat there in terms of an alternative to costly Obamacare policies. But certainly we were in discussions. I was in discussions with other state health directors, as I know the governor's office was too, through his office with their counterparts. But essentially, this idea came from the past several years. This didn't come out of nowhere for this particular rural health transformation program. We've been tossing around ideas for how to solve some of these problems with the rising cost of the ACA exchange, with the rise in healthcare costs and health insurance costs to small businesses. So this is really taking advantage of this opportunity to try to put something out there that Wyoming could design that would be innovative and provide options. Certainly nothing compelling individuals or businesses to participate, but an option to something that we have seen is a major driver of concern, both in the individual marketplace and in small businesses with the cost of health insurance.
Follow-up? Mr. Chairman, thank you. Director, what other states were you conferring with? Can you name off some of those states?
Mr. Chairman, in fact, just on Friday, I was in Denver with the director of Idaho's Department of Health, Montana's Department of Health, and Utah's Department of Health. The network that I was mentioning is, as I mentioned, 35 states. So it really does run the gamut of Mountain West states, Southern states, Midwest states, Not everybody participates in this particular network, but it's a mix of red, blue, and purple.
Follow-up? Thank you, Chairman. Director, so just listening to my own business owners in my district, they're concerned about OB care, the cost of OB, the cost of prescription. I mean, that's huge for them. So that's my question. That's what I'm hearing. Is any of this bear care, does it cover OB or prescription?
Mr. Chairman, Representative Angelos, no, it wouldn't. I think on another side of the application, the investments you see in OB, maternity care, EMS, critical access hospital services are through another mechanism within this proposal, not specific to the public health benefit or catastrophic coverage that we're talking about now, as an option for individuals and businesses.
Okay, thank you. Follow-up, Mr. Chairman? This will be my last one, but Director, I just, looking back and, history always provides us with looking forward and what, we definitely don't want to repeat it. And anytime the government has gotten involved in healthcare, education, home loans, those industries have gone up in price significantly. So that's what scares us on this, is you look back at the past and you look to the future, and that's my concern. So we're going to get involved in something, and we're going to be a driver in causing the cost to even go up even more. And especially when this isn't going to address the issues that I'm hearing from my constituents, my business owners. So thank you. Wouldn't you agree?
Representative Pendergraft.
Thank you, Mr. Chairman. I've been looking at the unit narrative on the insurance department's health insurance pool. And I should probably preface this by saying that I agree with some of the comments that we've heard earlier. I don't see how this is the proper role of government at all. And to go into competition with the free market generally, as was just pointed out, seems to cause negative impacts. But laying that argument aside, I spent 17 years, most of that as a partner with a construction company. We employed about 25 people, most of them young men. When the young men were asked to contribute to their health insurance, most of them opted out. It's just not on their radar right there. They'd rather have the cash. I guess what I'm trying to get is why you think that Gordon Care, Bear Care, thank you for not calling it Pendy Care. Why is it going to be more successful? What makes it more inviting than those products like those offered by AFLAC? Indeed, even this insurance pool, which has a whopping total of 640 participants in the state of Wyoming. What makes this different? And why do you think it might be more successful?
Mr. Chairman, Representative Pendergraft, if I can defer that to our Deputy Director, I'd appreciate that, because it's a very good question. At a high level, I would just mention there's a few areas, and we're really not trying to design this around competing with the private sector. There are a few areas of healthcare and health insurance that, frankly, the market, especially in small states like Wyoming, for insurance is not viable. Long-term care insurance is an example of that, where folks can pay into those policies for years, even decades, without a guarantee that those benefits will be paid out when they need them for nursing home care, et cetera. We see that a lot in that market. I think in a similar way, one of the benefits, and all of your points are well taken about government-run enterprises. I get that, and I take that seriously, of where we can be successful and where the proper role is for us to be successful. But there is a benefit of the state and the federal government in certain areas of the healthcare market offering coverage and guarantees of coverage. I think there's a trust factor there that we'll see. If this were approved, we'll see how popular and what the take-up rate of something like this, both from individuals and small businesses. And frankly, we don't know what that would look like. But Representative Pendergraft, your point's well taken. I'll defer to Mr. Fuchs here to offer some insight.
Mr. Chairman, Representative Pendergraft. So if you look at the market today, what is allowable? The ACA generally, prohibits health insurance that doesn't comply with the 10 essential health benefits. There's significant, so actually health insurance itself is highly regulated. What you have left is sort of these, the short-term limited duration plans, maybe they only last for a few months. Many are fixed indemnity type plans where they'll pay up to a certain amount of money, $100,000. Many of them are more or less transparent in what they offer to the consumer, and they may certainly meet people's needs. With the difference with this particular plan, I think the director mentioned, there's more of a trust factor there. So while we would cover these emergent type episodes, be very clear, this does not cover all your elective and shoppable stuff. This only covers the emergent stuff. But we're not going to impose arbitrary caps. We're not going to do prior authorization. We're going to do the best job we can to cover that episode of care in full and protect people from that financial ruin. So there's a trust factor there. It's a unique product because it is, in some ways, a private health insurer cannot sell this type of plan currently under the ACA. Therefore, the way we're doing this is saying, hey, we have to have a state-operated benefit plan here because state programs don't fall under that same purview. We offer, for example, a colorectal cancer screening program, which only offers colorectal cancer screenings. That's kind of why we put it under this sort of state umbrella, is to kind of offer this, both for the trust factor and the regulatory aspect. But to your degree, your point about a lot of people going uninsured, I mean, that's a very rational choice for a lot of young folks. If you look at your probability of healthcare costs, it's very low for young people. So we feel that if you really focus on the premium, if you can age rate it, and if you can offer it at a really low price point, you can get more people to potentially buy it, maybe not. Enrollment, again, as the director mentioned, to be completely voluntary. So we'd see the success or failure of this program on the enrollment side. And because it would be self-insured, there would be no additional cost for people who aren't enrolled. The cost would be borne by the pool.
Other questions, Mr. Co-Chair?
Thank you, Mr. Co-Chairman. I have a follow-up to that. I don't know, maybe it was asked, but I'd like to know, what the participation rate of this insurance program that the state has, because it obviously is a long-term program. I think it's started in 2004. It's supposed to go through 2030. It applies only to those over 65 on Medicare, Medicaid or Medicare. Medicare under 65s, which is going to be limited to just those people that have had major injuries, that type of thing. So if you could get us, an idea of what the total number of people that qualify for that, Medicare under the age of 60, is it 60, I believe? Trying to find it here. And if that's the case, we know we have 660 people that are enrolled in this optional program. That might give us an idea, how's this work in Wyoming? What's the demand look like? Are Wyomingites really interested in supplemental insurance from the state? I think that would be helpful. I'm referring to, within our insurance department, they mention it on page 19 and 20 of their budget, which is Agency 44. So there's a program out there already that the state's done. It's a long-term sustained program. And is that being successful? Might give us an idea.
Again, I'm going to give leeway on this issue. It's very important. So are there any other questions? Anyone else? I want to make sure everyone has the ability now to answer these, to ask these questions. Okay, Director, proceed.
Thank you, Mr. Chairman, members of the committee. Great discussion. And now we can start the Department of Health budget. Mr. Chairman, total chair and committee purview here. We've done it multiple ways in previous years. Listening into some of the hearings last week, it looks like the committee is going unit by unit through the agency budgets and noting any exception requests that are in those units. Happy to do that, or we can focus on the exception request priority table. Either way is fine for us, Mr. Chairman. Mr. Chairman, we'll start on page 64 of the department's budget. We will go unit by unit. The first unit is the Director's Office, Unit 0101. And you'll see there is an exception request on page 65. It's priority number 8, Medicaid Technology Project Management Office Staffing, and this is a carryover request from the last session where we're trying to convert a few AWAC positions to permanent. This is a net cost savings. Mr. Chairman, if it's okay, I'd like to defer the discussion of this until we get to the Healthcare Financing Division. The reason that you see an exception request in the director's office here related to Medicaid positions is because we actually have the ability to reduce cost in the director's office in this area. But it dovetails with priority number 9 on page 82. And if it's all the same to the committee, we can get there. Mr. Chairman, moving on to page 67, also in the director's office, exception request priority number 33 is TRP. I'll ask our CFO or budget director if they would like to weigh in here. I heard in the committee hearings last week that budget office and ETS had taken TRP and computer replacement as a macro, but we're happy to answer any questions you might have about that.
Yeah, I think we'll do what we've done last week, so.
Mr. Chair and members of the committee, Eric McVicker, I'm the Chief Financial Officer for the Department of Health. You'll probably be hearing a lot from me because I'll do the page turn as we go through here. I may answer some, but we'll kind of go back and forth. So next unit is on page 72. We're still on the Director's Office, and this is the Vital Statistics unit. There are no exception requests in this unit. That ends the Director's Office. If you turn to page 79, this is the Healthcare Financing Division, and this is the first unit, Unit 401. There are 4 exception requests in this unit. The first one starts on page 81, priority number 7.
Mr. Chairman, members of the committee, page 81, exception request priority number 7. We are requesting 2 positions here for Medicaid long-term care eligibility processing. This is something, a topic that we discussed at length with Chairman Pendergraft and the JAC subcommittee. We are seeing, and this also, I should mention, Mr. Chairman, was a request that we made last year as well. And so there's a few of these requests that you'll see that are similar to requests you saw in the supplemental session last year. And versions of those, in some cases, were supported either by JAC or both floor chambers, but ultimately were not reconciled with the failure of the budget.
Thank you, Mr. Chairman. I'd like to turn back to page 80 and just point out that similar to the several previous biennium, the governor has recommended that this Department of Health has superflex within their agency on their standard budgets to meet unforeseen significant issues. And we have used that responsibly in the past, and both Director and I can answer your questions to whatever extent you need.
Mr. Co-Chair.
Thank you, Mr. Co-Chair. Just a bit unrelated, but for Director Hibbard, what are the other agencies that have that superflex?
Mr. Chairman, we talked with the public defender last week. They have the superflex and the need for the attorneys, inability in certain areas to be able to attract and retain. We have superflex in the Department of Corrections, and that is associated with the out-of-state placements. There may be a couple of others, and if we come across those throughout the next couple of weeks, I'll point those out to the chairman.
Proceed.
Thank you, Mr. Chairman. Thank you, Director Hibbard. So committee, we'll go back to page 81, priority number 7. These are 2 positions in my long-term care eligibility unit in Medicaid. These are staff that process long-term care eligibility applications. These are services for nursing homes, for the DD comprehensive and supports waiver, for hospice care. These are usually very complicated applications, both on the financial and the clinical eligibility side, so we process them in-house as opposed to our contracted customer service center. What we've seen in recent years is a pretty dramatic growth in the volume of applications we're receiving, mostly from seniors and disabled seniors who are in need of nursing home or long-term care coverage. Over the past couple of years, our average caseload for each one of these eligibility workers has grown to over 600 cases per individual that they're working at any given time. And in fact, in the last 12 to 18 months, in some cases, processing, being responsible for 700 cases under their caseload. What that results in, members of the committee, is frankly some burnout, and also, more importantly, on the customer service side, wait times, delays, errors in processing those. And so for our elderly folks who are depending on at least knowing their options for long-term care coverage, we believe this is an important addition to the Department of Health. It's not something I take lightly in requesting positions, but you'll see here on the financing breakdown, because of the type of work that these individuals do in our eligibility system, we can leverage 75% federal match here for the salaries and benefits of these employees. Mr. Chairman, with that, happy to answer any questions.
Representative Pendergraft, and then Representative Harrelson.
Thank you, Mr. Chairman. I would ask you, Director, to describe a little bit more about the task that these people are challenged with. And in relation to, I personally am very concerned with the screening process to make sure that we get these benefits to the people who do qualify and who need them, and that we screen out those who may be trying to game the system, so to speak. So if you would describe a little bit about them and a little bit about the screening process and just exactly what they do, in relation to as well, if it is the pleasure of this committee to perhaps increase some of those screening measures, what effect that has on this division. Thank you.
Mr. Chairman, Representative Pendergraft, appreciate that question, now joined by our state Medicaid agent to my left, Jesse Springer. Essentially, these staff are responsible for exactly what you just mentioned, to make sure that we are applying both the state and the federal requirements for eligibility on these types of services as stringently and strictly as we can. So that involves collecting application materials, financial statements, financial information that we're putting through our system, but also verifying with the individual applicants to ensure they meet the state and federal criteria, and in this case, specifically on income. There we go. Financial assets, income, et cetera. In long-term care eligibility, these applications, as I mentioned, can get quite complicated with the various ways that folks save their money, use trust accounts, things of that nature. But essentially, these eligibility staff are responsible for that. And Mr. Chairman, Representative Pendergraft, happy to defer to Mr. Springer for additional detail.
Chairman, Representative Pendergraft. So what this staff does, they have the most difficult applications. So we have the more streamlined applications out at a private contractor. So those are mostly based on the family income. This group does our highest cost programs. So nursing home, community choices waiver, comprehensive waiver, hospice care, support waiver. And those programs by federal law require us to check assets or resources. So we're not just checking the income, which in some cases the income can be relatively complicated with retirement accounts, Social Security, other things. Some people have earned income as well. But with resources, we are enforcing Wyoming's current limit, which is $2,000 of financial resources. And that's a whole collection of things that you may not commonly think of as financial resources. So these are bank accounts, but it could be a prepaid funeral plot that is refundable. It could be whole life insurance that you can get cash value from. So there's a whole collection of things that are relatively hard to verify. Value of the home. Right now we have a $730,000 home value limit. So we have to value that. In some communities of Wyoming, there hasn't been a home sold in that community in a very long time. So there's no market values. And those require an appraisal. So there's just a lot of work on these limits to look at that asset or resources and say, what's the whole picture of this person? So that's what this staff is doing. As we've added people to the community choices waiver primarily, and also as the legislature has funded slots on the comprehensive and support waiver for individuals with intellectual disabilities, developmental disabilities, there's not been any staff added to this group. And so it's just gotten to the point where they're very behind. And so we're taking as many actions as we can. We've invested in technology, which is making some difference. We have shifted staff from other work groups as vacancies have appeared into this work group to try to drive. We've recently done but those are the main things we can do. But fundamentally, this type of work just requires workers. And so that's where we are with this group. Thank you very much.
Thank you, Mr. Chairman. Good to see you, Mr. Springer. My brother from another mother. I wonder if you could touch on part of what I asked before was if this committee decided to strengthen the screening process by some means that may add to the task that these people have and complicate it. On the other side of that is if they're successful and they find fraud, waste, and abuse, do you have any kind of an idea of the return of investment that may or may not be available here?
Yes, please.
Chairman, Representative Pendergraft. So one thing that we do, we're audited by the federal government on our error rate. So it's called the payment error, it's called PERM. I don't know what the acronym means off the top of my head right now. And they check to say, hey, did we determine the eligibility correctly? And so our error rate, I think in the most recent cycle, is going to be 3.5%. So that's pretty good. But the federal Big Beautiful Bill Act has set that to be 3% as the threshold that we need to meet by 2030. Otherwise, the state will experience financial penalties. So we think it's definitely within our grasp to have a very low error rate, but part of that is the staff is running at a much higher ratio than we have historically. And so they are checking a number of things. We're checking citizenship. We are now getting a monthly file every month from the Trump administration saying, check these 1,000 people for citizenship. They're not having a perfect match. We have checked every single one of those lists. We found one or two people that slipped through, but we're automating that citizenship verification so that that's happening in real time. There's been groups that the federal government has told us not to do citizenship verification on in the past, like foster care, for instance. Now they're doing data matches on those to make sure those are citizens. So that's fine with us. We've just been trying to comply with guidance. If the Department of Family Services sends us a child and says they're eligible, we accept them and cover them for healthcare coverage. We have not in the past been checking citizenship, but we're beginning to do that now. So that's just an example, but we are also checking residency. We have a data match that compares all the states to say, where does this person actually live? You cannot legally be enrolled in Medicaid in 2 states, so we are now, that's actually a very clean list. We have one of the cleanest lists in the country on that. A number of identity verification type things with Social Security Administration, Homeland Security, and so those are all automated data matches, and we keep investing in those things over time. And then on the asset side, we are doing a lot of research to make sure that we are uncovering all those resources and making sure that individuals that don't qualify are not getting into the program. So those are the controls that this group is enforcing. So being accurate, just for context, these individuals are controlling access to program costs that's about $400 million a year. So a 1% error rate is $4 million. So, these are big dollars that this staff is controlling. And benefit errors are done at 50% federal match, which means we spent money on benefits that we shouldn't have. These staff are at 75% federal match. So, even the federal match is favorable.
A follow-up, and then I have Representative Harrelson, Senator Larson, and Senator Guru.
Thank you, Mr. Chairman. I appreciate the breathing room. I do have a follow-up and then one other short question. So the follow-up, you mentioned the audits. You mentioned 3.5%. When was that audit done? Is that the most recent audit? When do we anticipate the next version? Because I know the ground rules have kind of changed now that we're moved out of the COVID.
Chairman. Representative Pendergraft, the audits we undertake, so there's every 3 years we're subject to the PERM audit, which is our federal audit on eligibility. We should get our results from our most recent completed just within the next month or so. So those numbers, it'll either be 3.25 or 3.5. We haven't got our final results yet. So usually when we're down to this point, we're disputing 1 or 2 cases to say we think we've done it correctly. This secondary private auditor disagrees with us, and we're just getting down to those details. The single audit of the state, we also participate in that. They do some auditing of us every single year. There's an IT audit and an audit of claims where they pull a claim sample. In addition, we have an internal group of individuals that actually audits our eligibility function constantly. So they're trying to find errors every single month. So they're pulling random samples every month, and they're an independent group that's looking at our client services group. That group lives in our program integrity function, just trying to find errors, what's causing errors. And in some cases, just one staff member needs to be retrained. But in other cases, there's something wrong with one of our systems and we need to go fix it. We go back and fix it. We find everybody who's subject to that error. So there's a lot of auditing. We have an audit really starting every 2 or 3 months, to be honest. So we're just constantly audited by different federal agencies, Office of Inspector General, CMS. We're just under basically a constant audit cycle. So we have a lot of external parties looking at us, looking at our data. In addition, we have something called TMSIS where we send monthly data files to the federal government. The federal government is now because the data quality of those has risen nationally. Ours has been good for years. We are being audited on those as well. So they're running algorithms and all sorts of analysis to find any type of error and sending us back reports to say, we think you might want to look into that. So there's just a lot happening in this space, but I do think it's finding the type of situations that you would be concerned about.
Thank you, Mr. Chairman. Last question. We spoke with the Attorney General's office recently, and they mentioned recovery of assets after death. You mentioned a $730 cap on the home value. Do you work with the county assessors on that? Could you describe that process briefly?
Chairman, Representative Pendergraft, when an individual receives long-term care from the state of Wyoming through the Medicaid program, that person becomes subject to estate recovery, asset recovery. So that could be cash assets, but from the description, cash assets are very limited because they have to reduce those cash assets to get access to the program. So usually it's joint property or a home. And so what the estate recovery group in the Attorney General's office does is file liens against those property, and then there's just work to recover on those properties. So that is one revenue source. It's between many years it's $2 million, some years it's been $5 million, just depending on the size of the estate or trust that the state is recovering from, and that's just a revenue source that the state has for funding the Medicaid program. It's required by federal law to have some level of estate and trust recovery. There are choices the state can make in those programs in terms of exemptions and things like that. But Wyoming has a very aggressive estate recovery program that targets not only long-term care expenses like the nursing home expense or the actual home and community-based service expense, but also medical expenses. So there's some states that have made different choices on those type of expenses.
Thank you, Mr. Chairman. And as we talk about this, a couple questions. First of all, what is our average time for these applications to be processed and these payments to get back to our providers and our communities?
Mr. Chairman, Representative Haroldson, I'll answer very briefly and kick it over to Jesse for any color commentary. So talking about two things. One is processing the eligibility application. Second part of your question was about payment to providers. So two different things. I believe right now our eligibility applications in the long-term care area are around 45 days, maybe a little bit higher than that, which is something that we want to greatly improve. Folks waiting that amount of time to have eligibility processed creates issues. If you have a loved one that needs nursing home care, et cetera, or a facility that's waiting to see if someone will be eligible to plan, what payment or revenue they will get. It's something that this request specifically helps us do that, and leveraging 75% federal funds to do it. I feel it's a modest request to beef up that staff that are frankly working 50, 60-hour weeks, coming in on weekends to clear backlogs, and still we're 45 days plus on those applications. We want to get down to 2 weeks. I just think that's an aspirational goal that we have. In terms of Medicaid payments to providers, we are very fast in paying providers. Talk about two kind of separate things here. Jesse mentioned our eligibility errors that get audited by the federal government, and nationally speaking, relatively speaking, we're quite low there, even though we always want to be better. On the claims error side, we are one of the, if not the best in the country in our payment errors. And going with that, through the automation and investments that this body has made over the last 10 years in directing us to update and modernize our technology, I think we're a day or two in a clean claim coming in and making payment to providers, 99% of which is electronic. So we're pretty fast on the payment side. The problem that we're seeing in one specific area, which is very high in demand, but also, as Jesse mentioned, a huge cost center for the department, is in this particular area where on the processing of applications, we're just falling behind.
Follow up?
Yes.
Thank you, Mr. Chairman. Thank you for that description. Can you talk about the renewal process and how often they need to renew and what that timetable looks like as far as when they submit a renewal to when they get that renewal verified from your office?
Chairman, Representative Haroldson, the renewal process is annual for most of these populations, so they are showing their income, their resources, and for many of these programs, the home and community-based programs, we're re-verifying their medical or functional necessity. So just an example, Community Choices waiver, they're going to have a public health nurse go out there and do an assessment and just verify the continued medical need for those. So the renewal, most people don't have a lot of change in their income once they get on these programs. Their assets are pretty stable or declining. Their incomes are usually stable. They're on Social Security and some sort of retirement plan. But we do have to verify all of that again. So renewals are generally a lot faster. Once you've proven those things, you're just looking for changes. To the extent we can, we're allowed to do something called ex parte, which just means we can trust data sources that we have. So we can get a data feed from the Social Security Administration to say what those payments are. If they match what the person is telling us, we can trust it automatically. We can get payments from retirement plans and the major retirement plans in Wyoming and not have to get that from the individual. So the more we can do that, it is a lot faster for the individual and it's easier on this team. So those are investments we have been making over the last 3 years or so in this area. This just doesn't have high automation just because there's so much manual paperwork you have to verify, and there's just not a great way currently to automate those things.
One more follow-up. Thank you. And so it's safe to say the bottleneck that you're facing is in new applications more than in renewal of applications?
Chairman, Representative Haroldson, it's really both, because the same team is doing renewals, which we have a bigger body of people that are doing renewals. We just have a lot of people enrolled, and this group, the long-term care group in both developmental disabilities, acquired brain injury, and the aging population are just growing. And so we just have more people. So the renewals is taking more time. Usually they have now dedicated a few team members just to doing renewals because they are faster. And then the new applications can be really complex because, just to be clear, most people that apply their first application, they don't qualify. They need to make changes to reduce their resources. They need to sell off property or sell off a second car and get that cash and spend it on their own care first before the state will pay. So a lot of these people are in the cycle of applying for Medicaid for 6 months or 9 months because the asset standard is so low. It was set over 20 plus years ago at $2,000, and $2,000 20 years ago was about $10,000 today. So, just to get down to that $2,000 level is very challenging for people, because if people have made good financial decisions, like buying a whole life insurance plan, they need to liquidate that before they can get onto Medicaid, because usually the cash value of that whole life plan is more than $2,000. If they bought a prepaid funeral plot, but they didn't read the fine print that it was refundable, they have to work with the funeral home to make it non-refundable. There's just a lot of kind of details like that maybe are, and to be honest, people feel like a lot of that's gotchas. And so we're working with families, we're working with, sometimes the individuals we're actually going to serve are not really mentally capable of doing this for whatever reason. And you have a family member or guardian trying to navigate this process and doesn't know where mom and dad's paperwork is. They don't know what drawer it's in. So, that's the challenge that this team is really dealing with. If everything came to us nice and neat, it would go pretty fast, but these are usually not nice and neat. This is kind of like the junk drawer, what have people purchased over time, and then you're trying to put it together.
Senator Larson.
Mr. Chairman, thank you. And thank you for being here again. It's good to see you. It's been a little bit of a short time. What is the current number of staff doing this? And you probably told me this before. And what is the total annual cases, I guess?
Mr. Chairman, Senator Larson, we'll verify this. I don't want to misquote. I believe we have 12 staff in this long-term care eligibility unit currently. Total number of cases for long-term care, we'd have to pull that. We could probably get that to you today, but it would be, I believe, in the thousands.
Mr. Chairman?
Yep.
Going back to the limits of the $2,000, is that set by this legislature? And you said that was back in '03, is that what I heard?
Mr. Chairman, Senator Larson, so the $2,000 asset limit to qualify for Medicaid long-term care, I don't believe that has changed since the late 80s or early 90s. And yes, the state does retain flexibility to change that. So this body could modify that. It's been in place for many years. And we've talked about that both within this committee and offline with a few of you. Essentially changing that would result, if you took it up to 5,000 or 10,000 in terms of asset limit, you'd see a corresponding amount of enrollment and then, member months coverage or cost on the state side. It is more gradual than you'd think. So the knee jerk for, an idiot like myself is to say, well, if you double the asset limit, you're going to double your enrollment or double your cost. It really doesn't pan out that way, because folks in long-term care settings, there's kind of an arrival and an attrition rate. So you essentially calculate it by how many more average member months would the state then be covering. And I think we've provided that detail to the committee. We can certainly follow up on that as well.
Senator Guru.
Thank you, Mr. Chairman. Question, we talk about, you need these two folks so we can process claims faster. That's the general gist of it. And in the questioning, we've heard a lot about why that is. And it sounds, I'm just trying to get a flavor for it versus how many people say, you got me. I'm trying to game the system and you caught me, so goodbye. Versus, oh, I didn't know that. I filled it out wrong, or I didn't know I had to do this. First, tell me, what kind of difference between the two of those? I mean, who's in the lead on that one?
Mr. Chairman, Senator Guru, it's heavily skewed towards the latter. As Jesse mentioned, this is a heavily, legal and administrative process when it comes to financial documents, records, things of that nature. So more often than not, it's folks realizing what they need to do in the future to be eligible for this, relatively high cost care. But it's hard to say because you have a really mixed bag of how people plan for long-term care. So in some cases, you're dealing with applications where there's complicated financial instruments and trusts and words that I don't fully understand, like half loaves and reverse half loaves and things like that. But I would say the majority are people who, they're reacting to a situation. I've been there myself. We've all been there of mom, dad, or grandma or granddad is in need of care right now, and we need a facility, and how do we pay for this? And therefore the application process starts, and some of those rules and standards then become learned, and we work through that process with them.
And thank you, Mr. Chairman. And when you talk about someone comes in and they're applying and you say, well, what you need to do is sell off this so you can qualify for that, or make this change in your trust, or sell off this asset so you can become eligible. What they're looking at when you answer that question is they're looking at, I've got this long-term healthcare bill at X $1,000s a month that could go on for I don't know how long. So it could be thousands and thousands and thousands of dollars over years. So I'm trying to figure out right now how to game that out and budget it out in my own mind. Not so much that I'm looking to figure out how to qualify for this great program, so tell me what I need to sell to get there. You're trying to set them up for long-term success to be able to take care of a loved one who's in a situation. Would that be a fair way to characterize what it is that you do?
Mr. Chairman, Senator Guru, in a way, yes, but to be clear, we're not a financial advisor. Right. So we try to provide information on what does and does not qualify someone for this type of coverage. But when it comes to the planning for how they do that, that's really not a role of the state. Now, we try to be as helpful and as white glove treatment as we can to make things that are very complicated more clear. But that really is a burden that families face, is just understanding the federal and state parameters of a program like this. And again, to be clear, I think there's good justified reasons for that this is not a program for everybody. This has some pretty strict limitations on it. And we talked about this at length with the JAC subcommittee this fall. It's just an interesting statistic for me that with our relatively low asset thresholds and income thresholds for Medicaid long-term care, $2,000 is not a lot of money. And most of our applications in this area will deny because of that, where someone has $3,000 or $2,500 or $5,000, and that becomes the problem for eligibility. Even with those relatively low, stingy asset and standards on the financial side, we still pay for 65 to 70% of all nursing home bed days in the state. So we're still the biggest payer in this area, even with those limitations on finances, which tells me the demand, and with our aging population, is just growing and growing and growing.
I'll follow up.
Go ahead.
Okay, so I got that. So let me ask you this: with two more people and hopefully then lowering the time it takes to qualify, how do you do this? Because I know this is an issue that, okay, you get in the program and you're paying, and then something in the applicant's life changes. Great Aunt Matilda, 3 generations back, all of a sudden you found out got left some money, and now all of a sudden your asset picture changed. Will these 2 people help as you go back through and do the reapplication process to make sure that the people who are getting this service are continuing to qualify for the service as the years go by, so we don't all of a sudden find out that, you know, the people, and sometimes they don't even realize that it's happening, but then there you are.
Mr. Chairman, Senator Guru, short answer is yes. On the renewal side, this will absolutely help. Just to summarize for the committee, what this, I believe it was $63,000 of general funds with a corresponding $190,000 of federal funds. What this buys me 2 people to help with the backlog of long-term care applications and ultimately speed up those processing times and serve those constituents and families faster. This is a tough thing for them to deal with, especially when there's potential errors, because we're working these staff with 650, 700 cases. It's a customer service issue for me.
So, Mr. Co-Chair, and then Representative Sherwood.
Thank you, Mr. Co-Chair. This question is for you, Director. You know, this came up on the floor last year. This body tried to eliminate some vacant positions. And I'm looking right now, as of the last payroll in November, your agency had 362 vacant positions. I understand this is a 75% cost share with the federal government. Have you looked at your vacancies and tried to eliminate vacancies, or at least transfer to get to these positions? And since this is our first FTEs we're talking about today, I just want everybody to understand that you're asking to add 19 FTEs in this particular budget, 19. You're eliminating some of those positions overall by eliminating 12 part-time and 17 at-will employees, so a net 10 negative, but you know, we are adding 19 new FTEs. So of those 19, are we looking at ways to reduce the number of vacant positions out of that 362 vacant positions?
Mr. Chairman, Co-Chairman Bear, appreciate that question. Yes, in this particular area, over the past couple of years, we've moved vacant positions that we could move into this unit. I believe 1 in the last 2 years, maybe 1 prior to this current biennium. We can verify that. To beef up this unit, Jesse has also prioritized a position or 2 in his own division to move work over to help with this backlog of applications. But to your point, the vast majority of those vacant positions are direct care nurses and CNAs at the facilities. Mr. Chairman and Co-Chairman Bear, the reason I'm reluctant to use those vacancies, which we could do to help fund this or to help allocate these positions, is we are currently using just near 100% of those vacancy savings in the direct care facilities to finance contract labor that, again, we reluctantly purchase. But the reason we're buying contract labor when we can't recruit those state nurses, CNAs, et cetera, at the state hospital, at the Life Resource Center, for example, is so that we can keep bed capacity open for the courts, for law enforcement and jails, for hospital emergency departments, in the demand for Title 25 and Title 7 placements at our facilities. But it's a good question. Could we move positions from those vacancies over to fulfill this need? Yes, but it's kind of like pushing on a balloon. I'd need to reduce capacity in the labor that we have at the facilities. And I think you already heard from Department of A&I on the compensation requests, and if they didn't discuss the direct care impacts of that for the Department of Health, I think it's important. We think that would be very beneficial because contract labor at our facilities is very expensive. We're often paying 2x, 3x what it would cost us to pay a state nurse or a state CNA in contract labor and paying that premium. So a modest increase in those competitive wages would go a long way. But Chairman Bear, as you know, that's what drives our vacancy rates, and we essentially hold those. We're trying to recruit them actively every day, every week, every month. but not as successful, especially on the entry-level nurses, as we'd like to be at the current rates we can pay. Eric and I, we lock those 100 series vacancy savings down and basically use all of it to finance that contract labor.
Thank you, Mr. Co-Chairman. So I'd like to see some stats on how we compare to other states as far as contract versus state employee. And really, the only good comparison would be rural states. So if you guys could gather that information, let us know, how do we compare? Because I suspect that everybody is in this situation where they're having to use travel nurses versus staff. And that's the situation in the world that we live in today. So kind of want to get a grasp on how can we develop a plan to reduce that. I understand how you're using the funds, but now how can we get off of that program, and can we?
Mr. Chairman, Co-Chairman Bear, it's a fantastic question. We prepared a brief on some of that for the JAC subcommittee, but we'll revisit that in light of that question, see if there's anything we can add comparatively with other states. Just a caution, there's not a central data source there on, departments of health and, staffing contracts that we won't be privy to and the rates they pay. But as you just indicated, we can certainly reach out and see if we can get some anecdotal information. Yep.
Representative Sherwood, and then I'm going to take a break.
Thank you, Mr. Chairman. One, I just want to commend the committee on the depth of questioning. I think we're all just trying to absorb this and understand so that we can turn around and explain it on the floor to our colleagues. So I wanted to kind of go a 3,000-foot view, a little higher, and maybe offer a summary of what this exception request is. We are proposing to spend $63,000 in general funds to save not having to pay the federal government $2 million, $3 million, $4 million, right? So this is really about an error rate. So every 1% we are in error is a $4 million bill we owe to the federal government. So by us leveraging $63,000 in general funds to get these 2 new positions, it will lower our error rate and save us not having to pay the feds on that payment error rate. So that's how I'm going to explain it on the floor.
Chairman Salazar, Representative Sherwood, the main thing we're most worried about in terms of error rate is timeliness of processing the applications is an error in itself. So if we go over 45 days and the federal government audits us and the application was processed in 47 days, that is an error. So that error, while I think the actual functional errors of the applications is very low because I think we have a very quality focus, the timeliness error could be very costly if we don't come down because our current timeliness is not meeting that standard. So that's where we need to be most careful as this becomes something the federal government's going to be enforcing on is we need to be getting all these applications done in less than 45 days. So that's the main kind of point. I don't think we went into that type of error, but it's not an error that we would say we made an error, but the timeliness is definitely a concern. And the federal government, depending on that audit, could say all the timeliness errors count towards that error rate, and we're assessing penalties for everyone who was not processed timely, which would be very costly.
Mr. Co-Chair, and then we're going to break.
What are you at right now for days to turn these around?
Chairman, Co-Chair Bear, we are on track to be at or near 45 days in January if the plan that we've been attacking since I've become interim Medicaid agent and then now permanent. We've been working on this plan for about 3 or 4 months to shift staff in there, reorganize. We think it was 90 days. And so the staff has been working very hard. We think we're going to be in that threshold by January. But that's assuming there's not this surge of applications. We just got a surge of applications for developmental disability programs. So, we're kind of catching up and then falling behind.
Okay, we'll take a 15-minute break.
Check, check, check. Testing, check.
Director Johansson, please continue.
Thank you, Mr. Chairman. We'll move to page 82 of your Department of Health budget book, priority number 9. This is what I mentioned in my introductory comments that dovetails with the Director's Office request on page 65. Essentially, what we're asking for, Mr. Chairman and members of the committee, is to convert AWAC positions to permanent in our Medicaid technology unit. We talked a lot about the technology infrastructure that we've built in Medicaid over the past 10 years, modernizing systems, being able to verify eligibility, citizenship, finances, et cetera. It's largely been a successful project. When the legislature ultimately or initially authorized that project, again, back about 10 years ago to modernize the Medicaid technology, it authorized AWAC positions, at-will employee contract positions. And what we found over the years is that a few of these in very technical system areas are incredibly difficult to retain as AWACs because there's no paid time off, different benefit structure, et cetera. And what we find is when we can't fill or keep those positions, often our own technology vendors will poach them, the federal government will poach them, and then we end up relying on more expensive consultant contracts for that highly technical system work. This results, Mr. Chairman and members of the committee, in conjunction with the request on page 65, results in a net general fund savings because of the positions that we ultimately cut back in that time period where this project was starting from the director's office to give to the healthcare financing division in that effort. So we do have a net savings there of approximately $101,000 general fund. So the request on page 65 and the request on page 82 go in conjunction with each other, and hopefully the narrative, although it is highly technical, summarizes both of those together. Happy to answer any questions.
Questions? Any questions? Okay, proceed.
Next request is on page 83, priority 14 and 15.
Mr. Chairman, this one's pretty simple. This is a reduction of consulting and other contracts due to the addition of permanent staff. So in conjunction with our long-term care eligibility requests that we just discussed with you at length for those 2 positions, we believe through this we could eliminate about $250,000 of consulting contracts. Happy to answer any questions.
Questions? Proceed.
Page 84, the last exception request in Unit 401 is priority number 16.
And Mr. Chairman, this is enhancements to the eligibility system. Again, we just spent a lot of time talking about the ins and outs of all of our eligibility functions and system functions. As you'll see here, this is a $736,000 general fund request. In Medicaid technology projects, we get 90% federal match, so that $736,000 general fund ask comes with $6.6 million of federal funds. And you'll see on page 84, we have 3 categories that we believe these enhancements will fall in line with, both in terms of improving our member notices, our long-term care functionality, which we just discussed at length, but also compliance with federal mandates for new changes to eligibility in Medicaid programs, which I think on the technology side, we're set up very well, as Mr. Springer explained, to comply and even exceed federal expectations that have recently changed. Mr. Chairman, happy to answer any questions on this request.
Questions? Proceed.
Next is on page 89. We start a new unit, Unit 420, which is the Children's Health Insurance Program, or the CHIP program. There is one exception request. It starts at the top of page 90.
Mr. Chairman, on page 90, this is priority number 2. As you remember from our categorization of our Department of Health requests this year, we had 2 categories that I think are very important. Mandatory requests, which we are legally bound to bring this committee, and we'll talk about a few of those here in a minute, and also enrollment increases that we feel compelled to make the legislature aware of. This is one of those enrollment increases. For those who need a little bit of a refresher, the Children's Health Insurance Program, or CHIP, is basically Medicaid coverage for children who slightly exceed the traditional Medicaid income limitations, which is 138% of the poverty level. CHIP covers 138% of the poverty level to 200% of the poverty level, so slightly higher family income. It's again, a program for slightly higher income children that the Department of Health operates as a Medicaid lookalike.
How many children are in the CHIP program right now?
Mr. Chairman, I'll have to defer to,
Chairman, yeah.
oh, you have it here.
I do, actually. Our ending enrollment at the end of November 2025 was 4,646 children, 46.
And Mr. Chairman, between Medicaid children and CHIP children, just a little edification for the committee, kids represent about 2/3 of our Medicaid enrollment. So children are our largest enrollment category in Medicaid when you include Medicaid kids and CHIP. I will mention, Mr. Chairman, CHIP programs that every state operates has a higher federal match rate than traditional Medicaid. This is a 65% federal match program, so you'll see in the breakdown, this is a $4.7 million request that generates $8.8 million in federal reimbursements. And again, Mr. Chairman, I want to be clear with the committee. These are the enrollment increases in CHIP and the enrollment increases that you'll see later in our community choices or long-term care waiver. We want to make the committee and the legislature aware of these. There's obviously policy options with how to finance these, either through an appropriation or in some cases through wait lists, reduction in services. But we're bringing the straight enrollment increase that we're projecting for the CHIP program for legislative consideration.
Questions, and I know that in my neck of the woods, this is utilized. What is the age limit for the children eligible for this program? And then is this for dental coverage as well as doctor's visits? Can you educate me on that?
Mr. Chairman, the age limit for CHIP, I believe, is 18 years old and under. And then, yes, coverage would look very similar to Medicaid coverage in what's provided. We do have restrictions on some, optional benefits like dental, but with children, we do cover a bit more on dental than we do with adult dental coverage in Medicaid. But the benefits look remarkably similar to the Medicaid state plan.
And what is your ask again for this?
Mr. Chairman, our ask on a biennial basis for this enrollment increase that we're projecting is $4.7 million general fund, $8.8 million federal funds.
And that's to cover the cost of the increase enrollment.
Mr. Chairman, that's correct.
Questions? Representative Pendergraft.
Thank you, Mr. Chairman. I'm not really sure when this question should be interjected, but it centers around the FMAP, the formula. Does that apply to CHIP as well? Could you maybe explain what the FMAP, how that works for the folks that are here, and then where it applies and where it might not?
Mr. Chairman, Representative Pendergraft, generally speaking, across the board in Wyoming Medicaid, we are a 50-50 state, meaning generally 50% of the costs are borne by the state, 50% by the federal government. In certain areas, we talked about Medicaid technology prior, there are enhanced federal matches. And in CHIP, there's an enhanced federal match where instead of 50-50, it's 65-35. Federal government covering 65% of the cost and the state covering 35%. In previous years, some of you who were in the legislature on the committee remember we had an enhancement to that enhancement. And for a couple of years, the federal government was paying an 88% federal match rate. That has since ratcheted back down to the statutory floor that Congress has set for CHIP. So we're back at the traditional 65% match rate in CHIP. This request is pretty much a straight enrollment increase in what we're projecting in CHIP enrollment. And it's worth mentioning here, Representative Pendergraft, as we dove into this a little bit with the subcommittee, enrollment rates in Medicaid, whether it's kids, whether it's disabled adults, family care adults, employed individuals with disabilities, that does ebb and flow over the years, heavily tied to economic conditions around the country and in the state. This is essentially a calculation of the increased enrollment we have observed as well as projecting what we've seen in recent years of a projected 5% annual growth rate. So there are some estimates in here, and again, this would just be budget, obviously would not be expended if that enrollment does not happen, but this is what we believe is going to cover us for the 27-28 biennium in CHIP enrollment.
Yes, please.
Thank you, Mr. Chairman. Just a follow-up, hopefully brief. Would you describe for the rest of the committee and the folks watching the effect that Teton County has had on the state and our reimbursement rates?
Mr. Chairman, Representative Pendergraft, I'll preface my statement by saying this is with all due respect to the Wyoming residents from Teton County who may even be on this committee. But the income distribution in that county does heavily skew Wyoming's calculation for federal match, which is statutory. It is not something we have control over. There are no waivers related to the federal match rate in Medicaid, and certain states, Wyoming's one of them, Colorado's one of them, largely due to Summit County, as an example, where that per capita income is very, has a huge impact on the overall state's federal match calculation. I believe the highest federal match state is, I want to say Mississippi, in the mid 80s in terms of federal match. We are essentially a floor state with 50-50. So it does have a significant impact, and we've prepared briefs for the Joint Appropriations Committee in years past showing, and we can dust that off and send it to the committee if you'd like, showing what those effects look like.
Thank you, Mr. Chairman. So if I'm hearing you right, federal government reimbursement rates for each state depends on the average income. We have one particular county which tends to skew the rates, and so Wyoming then receives the minimal rate because of that. In that document that you just mentioned where you briefed appropriations, has there been any discussion about possibly taking some outliers where you have an extreme case like we have here and maybe tempering that to bring things a little more in line with reality?
Mr. Chairman, Representative Pendergraft, not only have we had those discussions with the Appropriations Committee, I believe in one year you all passed a footnote that required me to negotiate with the federal government on our match rate. It proved to be unsuccessful, again, because it's set in federal law. So that would take an act of Congress to change that calculation. But we did do an exercise to see what, if Teton County, if there were a waiver, the federal government offered flexibility and you could, either waive or limit the effects of one particular county's per capita income calculations, what that would do to Wyoming's match rate. If memory serves, don't quote me on this, but I believe it took us up to around a 60-40 split if that county were excluded. But again, I don't want to get the committee's hopes up. We don't see a whole lot of room for negotiation there with the federal government, as short of an act of Congress.
Other questions? Please.
Mr. Chairman, we're on page 92. It's Unit 431, Medicaid or Medicare Part D clawback. There is one exception request on the top of page 93.
Mr. Chairman, top of page 93, this is priority number 1, Medicare Part D clawback. You might ask, why is this my number 1 priority in the exception request for the 27-28 biennium? And that's because frustratingly, this is what I categorized for you as a mandatory request. This has a little bit of artifacts of history here going back to the early 2000s when Medicare Part D prescription drug benefit was created for seniors on the Medicare program. Again, Medicare is not something that the state operates, but when Medicare Part D prescription drug benefit was created, the federal government did a calculation on essentially, without that Part D benefit, what would the state's share have been in essentially pharmaceutical costs for these seniors? And when Part D was created, they did a calculation of what every state owes every year for what they call Part D clawback. Because the federal government was generous enough to create that Medicare benefit, they then charged the state Medicaid programs for what their share would have been. The reason this is a number 1 priority is a frustrating policy decision for this committee and the legislature that It does not matter if this is appropriated or not, the federal government will take the money out of our overall federal match rate, meaning we will be forced to find that funding somewhere. And this is one of the more frustrating requests I have to bring to this committee, where I feel compelled to bring it because we really have no control over this invoice that we receive from the federal government. Mr. Chairman, with that incredibly frustrating explanation, happy to answer any questions.
Questions? Okay, proceed.
Mr. Chairman, we're on page 95, Unit 432, dual eligible excluded drugs. There are no exception requests in that unit. Moving on to page 98, Unit 433, Medicare crossovers. There are no exception requests in that unit. Moving on to page 101, Unit 450, Medicare buy-in premiums. There are no exception requests in that unit. Moving on to page 104, 451, Wyoming health insurance premiums. No exception requests in that unit. And then on to page 106, Unit 460, adult services. There are 3 exception requests in this unit, the first one starting on page 107.
Mr. Chairman, members of the committee, this is what we discussed in our introductory discussion around supplemental payment programs. This is a relatively large request, but only for federal fund and other fund authority, no general fund request here, largely due to the growth of 3 programs, supplemental payment programs in Wyoming for hospitals, for private physicians that work in hospitals, and for ground ambulance, which is a relatively new utilization that Wyoming legislature authorized several years ago for us to build. So again, for hospitals, for ground ambulances, this is the program where we assess a fee to that provider group, collect the revenue, the federal government matches that revenue, and we redistribute it back to the providers as a cost coverage increase for the services that they provide to Medicaid members. This, again, is growth in a couple of areas, which is a very good financial mechanism to increase the sustainability of these types of providers, but it's generally in lieu of us having discussions with this committee about specific reimbursement rate increases. With that, Mr. Chairman, happy to answer any questions.
Proceed.
The next request is on the top of page 108.
Mr. Chairman, top of page 108, this is a carryover from last session. I believe both chambers supported versions of this request. This was a cost study that we did for Medicaid behavioral health rates in 2024 and presented to the legislature in our budget hearing last year and was discussed by this committee and by both chambers in the 2025 session. This is a rebasing on mental health and substance use services specific for Medicaid beneficiaries where we were paying above cost and in areas where we were paying below cost to rebase and balance that. This is a $1.7 million general fund request with a corresponding 50% match from the feds at the same $1.7 million for a total request of $3.5 million. Mr. Chairman, happy to answer any questions.
Proceed.
Mr. Chairman, on the top of page 109 is the last exception request in this unit.
Mr. Chairman, priority number 27, we are proposing to increase inpatient hospital rates for critical access hospital to 100% cost coverage for those hospitals that maintain OB or labor and delivery services. This is a relatively sizable biennial request, something we have discussed for the last 2 years with the Labor Health Committee. And essentially what this would do is bring all critical access hospital reimbursement rates up to 100% cost coverage based on the most recent cost studies that are conducted, basically for those hospitals that maintain this type of coverage. For those who may not remember, in the last 5 years, we've had approximately 4, maybe 5 hospitals that have discontinued OB or labor and delivery coverage around the state for a variety of reasons. This is an attempt to sustain what we have as an incentive for those critical access hospitals that continue to provide this service to do just that, continue to provide this service to their residents and to their region. Mr. Chairman, you might ask why, with the focus we've had as a state, as a labor health committee, as an executive branch on OB and maternity care, why this is priority number 27. And the reason for that is we believe that there's some interaction here. Sorry, Mr. Chairman, I feel compelled to pause here.
Let's wait a second.
Thank you, Mr. Chairman. Again, just to summarize, this is an incentive for critical access hospitals to maintain OB and labor and delivery services by increasing their reimbursement rates in Medicaid for the remainder of their services to 100% cost coverage, given the labor and delivery or OB discontinuations we've seen in a few hospitals around the state. The reason this is relatively low on the priority list is we believe there's some potential interaction in this area with the Rural Health Transformation Program, which has some uncertainty around it right now. And that's the reason that I ranked it a bit lower. But I can, as you all know, this has been a pretty significant priority for Governor Gordon, for the executive branch, and been on the interim agenda for the Labor Health Committee the past 2 years. With that, Mr. Chairman, it is a policy option that the state has on the financial side in Medicaid, where we represent about a third of the market. About a little less than a third of all births in Wyoming are Medicaid funded or Medicaid eligible births. So we don't believe this is a panacea to solve the OB, labor and delivery problem in the state, but certainly an option the legislature has to try to shore up or sustain what we do have.
Couple questions. Let's go with Representative Angelos and then Representative.
Thank you, Mr. Chairman. Director, just in talking with some of the OBs in my community, the real issue that we're seeing is that their malpractice insurance is so high. So if the malpractice insurance is so high, and that's why these hospitals have given up their OB and labor wards, how is this going to address that issue? Obviously, probably going to just shore up some of those, but I mean, that's where we're seeing the issue.
Mr. Chairman, Representative Angelos, it's a good point. In fact, several weeks ago, I was presenting to the Medical Society and we discussed this very issue. So I do think in pockets it is a challenge, and primarily a challenge with what we've seen more broadly in the physician market over the past 5 or 10 years, where the consolidations in the medical industry really have changed the dynamic of how physicians practice, where we're seeing more and more of physicians as employees or contractors of larger systems that have the scale to cover that cost of malpractice. So to give you a crude analogy or an example, far fewer, docs hanging up a shingle in a community versus, being an employee of or a contractor of a larger health system. So your point's well taken. To answer your question directly, this would not have any interaction with financing malpractice insurance for OBs or for physicians. This is a separate strategy, so to speak. But I know at the Labor Health Committee, and we potentially might see individual legislation this year looking to address that issue, which we've weighed in on, provided some options of what that could look like, both in Medicaid and more broadly.
Representative Pendergraft.
Thank you, Mr. Chairman. I did ask this in the subcommittee, and I would like to ask it again here for the sake of the committee as a whole and for the public that is watching. Could you define for us critical access hospital, what that means, how it differentiates from the others? Thank you.
Mr. Chairman, Representative Pendergraft, happy to do that. So critical access hospital is essentially a facility licensure designation for hospitals that are less than 25 beds or less, and that there's no other hospital within a 35-mile radius. So kind of is suggested in the term itself. It's a critical access hospital based on its geography and based on its size. And we can certainly provide the committee of a breakdown of the number of critical access hospitals we have in Wyoming, and then the other side, which we generally call prospective payment system or PPS hospitals, which are the other side of that licensure.
Mr. Co-Chair.
Thank you, Mr. Co-Chair. You may have had this discussion in the subcommittee. If you did, I missed it, but I'd like you to explain a little bit further what this 100% of cost, how that works. I know there's some other areas that we're looking at doing that in, and so is this, what I'd like to know, is this something that the federal government puts a cap on it, or is this something that sky's the limit? Because, you know, I look at Medicaid, you know, it makes about 30% of what the retail or insurance coverage would be, and anybody asking for more of that's going to go broke. My question is, if we go to 100%, is it all on the state to make up the difference? And is there a cap to where we're the ones going broke?
Mr. Chairman, Co-Chairman Bear, it's a phenomenal question. I'm glad you asked it, because there's always some confusion here of, if we just make a policy to say we're going to pay 100% cost, who's determining those costs? And is it just a never-ending ramp upward? So in Medicaid programs, as we discussed with some of our supplemental payment programs or upper payment limit programs, generally speaking, we are disallowed from using Medicaid dollars, which are state and federal, from exceeding the upper payment limit, which is the Medicare set cost coverage. In hospitals and nursing homes, all of those providers are required to submit annual cost reports to the federal government, and there's allowable categories of cost and non-allowable categories of cost. That's essentially how we back into what we believe is 100% cost coverage. And then in services like this, hospital services, nursing home reimbursement rates, other reimbursement rates in Medicaid, we are typically looking at where we are in relation to that federally set upper payment limit. So that's the limiting factor, is it's not a free-for-all for providers to say, well, our cost increased, and you know, we have a very expensive gift shop or marble tiles that we're adding, and that's what cost coverage would be. It's pretty strictly set by the federal government. And in many policy discussions with this body and with the legislature, we're often trying to bounce off of that to get a sense of not where we are in relation to commercial insurance or private pay or private charges, but where we are in what Medicare would have paid for the same service in those allowable cost structures. Co-Chairman Bear, does that make sense?
Other questions? Proceed.
Mr. Chairman, we're on page 111. It's Unit 461, Children's Services. There are two exception requests in this unit, the first of which is on the top of page 112.
Mr. Chairman, at top of page 112, this is priority number 6. And this is also a repeat from last session's request, where I requested emergency funding to increase our home health reimbursements, primarily for high-needs children. It's a relative handful of kids that are very high medical, high acuity, and without access to home health providers, often have protracted or lengthy stays in children's hospitals, like Children's Hospital down in Denver, which is in fact a higher cost to the Medicaid program to finance those inpatient stays. This was something I brought to the committee 1 year ago, and that we discussed in the legislative session this past year, where I had a pretty deep concern about the exit of some of these home health providers. In fact, one that reached out to us, I believe was in the Basin area, that was saying not only can we not accept new Medicaid children for this, but we think we might need to pull out of the program altogether. And the reason for that was, dovetailing off of Chairman Bear's comments a few minutes ago, we assessed these reimbursement rates that were around 46% of cost is where we were reimbursing. We had made the request last session to bring our reimbursements up modestly to 70% of cost coverage, where in discussions with those providers, again, based on their business model, and you have private pay, you have commercial insurance, you have Medicare, and in this case, Medicaid, could be sustainable and keep serving our high needs Medicaid kids. When the budget was not reconciled, and I believe the Joint Appropriations Committee supported this request to both floors last year, when ultimately the budget failed last session, I had several offline discussions with some of you about a number of our requests where I was asked, what can you do to bridge the gap between this failed budget and next session? This is one of those areas, given the concern I had about some of these children we were covering, where we did an emergency rate increase for the remainder of this fiscal year to bring us up to 70% cost coverage. This request would essentially reinforce that into the biennial standard budget for 27-28. Mr. Chairman, thanks for entertaining me with a little bit of history there, but I thought it was important. Happy to answer any questions.
So this has been a problem.
Mr. Chairman, yes, and this is a growing problem. You might recall several years ago, we brought a similar request for kids on the dental side, where we had, in discussions with the Dental Association, numerous dentists around the state, they were communicating with me and with us. We really want to serve these kids. It's just becoming untenable to serve them. And when you have multiple dentists in a community that are, essentially sharing some of that burden, so to speak, but you have one or two of those exit and the Medicaid coverage or the Medicaid service is falling on one or two dentists, it really becomes untenable. The legislature worked with us to, again, do a modest rate increase to our dental reimbursement rates for children. And I think that's been largely successful with the number of providers that we've been able to bring back into the program and kids that have been able to be served. And in our internal Department of Health performance management meetings we've had over the last 2 years, we believe there's decent evidence to suggest that when you provide that kind of coverage, you do avoid or offset, emergency department visits, things of that nature. Similarly here with this high needs home health service for pretty high medical children, we believe there's a cost offset for larger expenditures in very expensive inpatient settings.
This request will take care of that problem, correct?
Mr. Chairman, yes. We believe that this is a way to stave off the exit of some of these providers from serving these kids and us being essentially forced into continuing to finance expensive hospital stays. I wish I could say that this solves the problem in perpetuity, but as you all know, it's always a dynamic year after year going forward of reassessing where we are with some of our reimbursement rates, what's the role of the state in covering that service or providing that reimbursement. This is one that for our very high needs children, I think is important to make sure that we're at least tracking where we're significantly below cost coverage in those rates. And being at 46% cost coverage previously with this service, we believe it was time for an adjustment.
Any questions? Okay, proceed.
Next request is on the top of page 113, priority number 10.
Mr. Chairman, top of page 113, priority number 10, this dovetails with the critical access hospital request that we just discussed, but this is specific to the reimbursement rates for maternity and labor and delivery, specifically for physicians. This is also a carryover from last session that both chambers discussed. And essentially what we do here is we take those physician reimbursement rates for Medicaid births up to 105% of cost coverage, so an enhanced incentive there. And we try to maintain every other physician service around 90% of Medicare or cost coverage. The way that we make this work on a lower general fund obligation is that we, again, studied our costs. We found a few rates like anesthesia rates where we were, by some artifacts of history, paying well above costs, around 115, 120%. So we rebase those and bring them down while offering an incentive for physician services for labor and delivery here. To Representative Angelos's previous question, is this a panacea to solve all of our maternity care issues? No. But as a third of the market in Medicaid, we believe that in our discussions with the Labor Health Committee the past 2 years, we feel compelled to bring some of those financial policy decisions in the Medicaid system to this committee. With that, Mr. Chairman, happy to answer any questions.
Questions? Proceed.
Mr. Chairman, on page 115, we have Unit 462, out-of-home placements children. There are no exception requests in that unit. On page 118, Unit 463, nursing facility services. There are no exception requests in that unit. Page 121, Unit 464, hospice, no exception requests in that unit. Page 124, Unit 470, optional services, adult. There are no exception requests in that unit.
Representative Pendergraft.
Thank you, Mr. Chairman. Just publicly, I know that we had met privately aside. In the description to this, I think it's page 33 of the book, it talks about optional Medicaid services. And there's a list there, but that list is not comprehensive. And I guess I'm making a formal request for a comprehensive list, the optional items as opposed to the mandated items. And I would thank you for that.
Mr. Chairman, Representative Pendergraft, happy to prepare that, and from our subcommittee materials, I think we can replicate some of what that committee saw. You're right, in this particular unit, you see, generally speaking, all of the optional services that the legislature has authorized us to cover outside of waiver mechanisms, if that makes sense. So your DD, your developmental disability waivers, your long-term care waivers, those are optional services that the state has elected over the last few decades to provide. Outside of waivers, these are typically the services that are also optional, like vision, dental, hearing aids, hospice, et cetera. But we're happy to provide a table that shows that more comprehensively.
Other questions? Proceed.
Mr. Chairman, page 127, 471, Indian Health Services. There is one exception request, and it's on the top of page 128.
Mr. Chairman, this is priority number 5, funding for what is the federally calculated all-inclusive rate, or AIR. A little bit nuanced here, but the federal government has a treaty with tribal nations and tribal governments to fund 100% of healthcare costs. That impacts Medicaid programs in a few ways, but it's generally as a pass-through of 100% federal funds. This is a rate, an all-inclusive rate that's calculated federally, so this gets passed on to us. There's no general fund exposure, but you can see it's a relatively sizable request. We have also baked in a 10% projected annual increase for the biennium to budget just federal spending authority for what the federal government passes down to us in tribal reimbursements.
Are there any questions? Continue.
Mr. Chairman, page 130, Unit 472, Wyoming Life Resource Center. There is no exception request in this unit. On to page 133, Unit 483, Community Choices Waiver. There is an exception request in this unit about the middle of the page in 134.
Mr. Chairman, middle of the page on 134, priority number 3. Again, we've talked about a few categories in my budget request, in mandatory request and enrollment increases. This fits into the latter there, enrollment increases. We have seen some growth in our community choices waiver. So let me describe briefly what that is. Our community choices waiver, previously known as the long-term care waiver, these are for folks in Medicaid who qualify for nursing home placement, both in terms of their finances and in terms of their acuity, activities of daily living. They meet nursing home level of care. This offers a home and community-based alternative to going into a nursing home, which is generally cheaper to the state and the preference of most of our seniors to stay in their home or their communities. And this is what this waiver allows. Back in 2013, the legislature essentially uncapped that waiver, so there's no enrollment cap on it. And so similar to the CHIP program that we discussed before with kids, we've seen enrollment increases with Wyoming's aging population in this program. This is a 50-50 federal fund, general fund split, but you'll see it doesn't appear to be 50-50 here, with 11.2 million in general fund and 16.3 million in federal funds. That's because historically, over the past several years, our federal funds in this unit have been under budgeted. We've covered that through flex authority, so this is essentially, with that increased federal spending authority, shoring that up, but this is a 50-50 program, and again, tied specifically to increased enrollment in long-term care, and in this case, the community choices waiver. This committee in previous budget hearings and sessions and interims has asked us the question, does this program offset more costly nursing home stays and nursing home reimbursements from the state? And the general answer to that is yes, we think so. It's very hard to prove. It's very hard to say that if we didn't have this waiver, would we see all of these clients in nursing homes? The answer to that is probably not one-to-one, but we do believe, based on the analysis we've conducted over the years, that keeping folks in their home and paying much lower cost for home health and community-based services does, at the very least, delay and offset those institutional nursing home costs. But again, there's a policy decision from the legislature here going back to 2013 on uncapping the waiver and not having a wait list in this program. I think generally beneficial for the folks we serve and likely beneficial for the state finances, given how much more expensive nursing homes are than in-home services. With that, Mr. Chairman, happy to answer any questions.
So this is the home services program, correct?
Mr. Chairman, this is the Medicaid waiver for a similar type of service. What I believe you're referring to in Wyoming Home Services is a much smaller home services program in the aging division, not Medicaid. It's about $5 million a biennium for that program. Doesn't offer the same comprehensive array of benefits and is operated largely through senior centers, but similar idea in mission to try to delay the need to go into a higher level of care in nursing facilities. The Medicaid waiver here is much higher scale, much more comprehensive in the benefits it offers, thus the higher cost structure that you see here.
But we are dealing with seniors over 65. So I don't know if it was your department, Wyoming senior population, 65 and over is currently 111,865. It's estimated to be growing at the rate of 3.5 per year, which is the highest rate in the nation.
Mr. Chairman, we are one of the most rapidly aging states demographically. So we've done a few comprehensive studies for the legislature on the aging population. And by 2030, we do continue to expect significant growth demographically in that population, which, as one of the largest payers for long-term care in the Department of Health and Wyoming Medicaid, going back 6-7 years ago with this body and the legislature, have been raising that alarm that we will see enrollment increases, we will see more demand on these systems. And so I'm not surprised by these enrollment numbers, but it is something for our policymakers to consider on how we should cover that and how we should fund those services.
So whether it's the home services or this, it's going to be a continuing issue.
Mr. Chairman, that's correct.
Questions? Who? Senator Larson, and then we'll go with Representative Sherwood.
Mr. Chairman, thank you. What are those enrollment numbers in the past 5 years? Do you have those? You probably gave them to me before.
Mr. Chairman, I'll defer to our deputy, Mr. Fuchs. I believe he has our snapshot up right in front of him.
Mr. Chairman, Senator Larson, the community choices waiver back in 2016 had around 1,700 folks on it, and today, last month, the current enrollment was 2,354, so 2,354 people.
Anything else? Representative Sherwood, I apologize, it's just so hard for me to see you, and so please speak up. It's not that I'm trying to shortchange you, so please go ahead.
Thank you, Mr. Chairman. I understand there's a height issue and like a visual issue here, and I'm not going to I don't take that personally by any means. So thinking about Wyoming being one of the fastest aging states in the nation, and that you have projected out a 2% increase, I guess my question is that enough? Or should we be planning for and preparing for a greater than 2% increase of use of the program? Thank you.
Mr. Chairman, Representative Sherwood, I appreciate that question. I believe projecting into the next biennium, it's sufficient for a couple of reasons. One, based on the growth we've seen in recent years. Two, it's important to remember not everybody is eligible for this program just by nature of being elderly. This is the same income and qualification standards that we talked about earlier with long-term care. So for this program in particular, you must not only qualify financially for Wyoming Medicaid, but also clinically to be eligible for nursing home level of care. So there's kind of a joint assessment on the finances, and then a public health nurse will conduct a long-term care assessment with the individual to determine their activities of daily living, essentially their clinical acuity, if they would qualify for nursing home coverage. So those two limiting factors, Representative Sherwood, make me relatively confident that this is the right number here.
Want to make sure she didn't have a follow-up. Representative Pendergraft.
Thank you, Mr. Chairman. So looking at this 50-50 match that isn't 50-50, in 2017 and 2021, we had some reductions, and part of your ability or part of your methods were to, I guess, flex some federal funds. Is that what's reflected here?
Mr. Chairman, Representative Pendergraft, certainly a part of the drivers there, also just some artifacts of historical budgeting that we're cleaning up here. But yes, this is a 50-50 program, and some recent years have just changed some of the federal spending authority we have across units that, again, we're cleaning up. But it does look weird, and LSO actually asked us this question to say, you've said this is 50-50, but you have 11 million and 16 million here. That math doesn't add up. So hopefully we successfully explained the reasons for that to LSO, but same explanation here. It's really more of a historical cleanup.
Co-Chair Bear.
Thank you, Mr. Co-Chair. Director, you seem skeptical, and maybe I've just read into that, as far as the savings. It seems to me common sense that this would save the state money, keeping people in their homes longer, but we've had this program for some time. So are we gathering stats on whether it is saving us any money or not?
Mr. Chairman, Co-Chairman Bear, yes, we are, and we've been, just in the last several years, we're directed by the legislature to study it very directly. The reason you heard skepticism, and my own staff kind of derided me for this, I have a hard time saying causally to the legislature, yes, this saves this many dollars, because there's so many factors that go into it. You're absolutely right. Common sense, if you serve people in their homes at 40% of the cost of a nursing home, will you save or offset dollars? Absolutely. What we just have a hard time determining causally, we can correlate those numbers, but causally connecting those, you cannot determine if that particular client would have elected to go into a nursing home. Many don't. So we believe there's strong evidence to suggest that we are saving money by having this program, because a portion of that population would likely admit to a nursing home, which is higher cost to the state. But I think, trying to be as credible as possible, we didn't want to draw that direct causal conclusion.
Yes, please.
Thank you, Mr. Co-Chairman. And as a follow-up, are there other programs out there? You mentioned on the keeping them in the homes program, we have the aging program for $5 million. Are there other programs we're actually paying for the long-term nursing care, in-home care, not in-home, I'm sorry, in a facility?
Mm-hmm.
And if we do have something outside of that, do we have the requirement that this program has, where they have to prove that they physically need to go into a home, a nursing home?
Mr. Chairman, Co-Chairman Bear, it's a good question. So the major program that we have to finance facility-based long-term care is in Medicaid through our nursing home services, which we've discussed with this committee before. The only other real long-term care program we have outside of Medicaid that is similar in its mission is Wyoming Home Services, which we can discuss when we get to that budget unit, and it is much lower scale. And the way I like to think about it, and the way we've kind of moved those providers providing that service in recent years, is really as a pre-Medicaid option, if that makes sense. So you can target a population that might not be at that low income and asset threshold, or maybe slightly higher on or lower on the acuity spectrum. They're not quite in need of or would qualify for nursing home acuity at this point, but they don't qualify for Medicaid either financially or clinically. And that's what you see delivered through our senior centers and Wyoming Home Services, again, much lower scale. But in previous years, this committee directed us to look at options and negotiate with the federal government if we could kind of combine the two together with a special waiver to say, let's use Wyoming Home Services or something similar as a pre-Medicaid waiver and generate more federal match. We submitted that last year to the federal government for consideration at this body's request. So far, they have not approved it. We do meet with them regularly on the questions they have. They indicated that approval would not come in this calendar year, and they may revisit it next calendar year, and we can bring those updates to the committee if it should move in that direction.
Okay, continue.
Mr. Chairman,
Yes.
apologies from the staff table. I just wanted to remind the Joint Appropriations Committee that the next two units, Unit 485, Comprehensive Waiver, and 486, the Supports Waiver, is the one that you have been looking at as your interim priority number 3 for the DD waiver programs. So those next two units are the ones that you've been looking at.
Thanks so much.
Mr. Chairman, we're on page 137, Unit 485, the comprehensive waiver. There is an exception request in this unit on page 138.
So, Mr. Chairman, page 138, and this is in the comprehensive waiver unit, you will see another request in the next unit for the supports waiver. But I wanted to take a minute to just summarize, from my perspective, the discussions we had in the Joint Appropriations interim committee meetings, which we greatly appreciate the time that this committee dedicated to this issue. Presentations from the department, a lot of testimony from providers, from members of the communities, from even recipients of these services. The way we essentially approached this issue of funding in the DD waiver system was in 3 ways. 1, provider rates. 2, extraordinary care or emergency care situations that we find ourselves in with this population quite often. And 3, with the wait list. We tried to design budget requests to be responsive to the Appropriations Committee, but also in line with what we've seen happen in these programs over the past several years, to combine those 3 elements: provider rates, emergency care, and waitlist funding. We'll get to the first 2 in Unit 485 here in the comprehensive waiver. And what we have here is funding for what we call Extraordinary Care Committee, or ECC. So you might ask what that is. When folks are served on the Developmental Disability Waiver Program, there is a process for those case managers and those members to propose the need for additional funding for their case based on an emergency situation or a significant change in their situation or their services or their acuity, their needs. That is something that historically has not been budgeted in the Department of Health. We have covered it through float, but we have seen an uptick in volume in the number of ECC requests we receive. As we discussed with the interim committee over the summer and fall at length, you asked a lot of questions about the process that we have for that. Hopefully we described that well enough, but happy to answer any questions that you have. So we've incorporated a component of ECC funding into this specific request, as well as a request that you all saw or discussed last year in continuing reimbursement rates that were temporarily supported by ARPA funds, which have since expired. So this request altogether was approximately $10.7 million general fund and $10.7 million federal funds. And I'll punt a little bit to the next unit that we'll discuss, but I'll certainly pause now so we can discuss this one. But we did bring those requests together. This one here in 485 and the next one that we'll talk about in 486 to bring those 3 policy items for discussion. Mr. Chairman, I know that's a little bit nuanced and long-winded, but I'll pause there since there was so much significant committee discussion on this topic. See if there's any questions we can help answer.
So, and we can combine the conversations on both these, but throughout the summer, we had talked about having a goal of not eliminating, but lowering the wait list. We had talked about particularly the interest on level 5 and level 6 needs. And then obviously the providers' rates to make sure that there were actually people in these facilities that could handle the added burden of lowering that list. So given what you've come to this committee on with regard to the exception request, is that going to do it?
Mr. Chairman, excuse me. Yes and no. So this request does not, these requests together, and I'll point the committee to page 142, which has the waitlist funding request and the supports waiver. That's in Unit 486. But yes, you're right. All of these together, provider rates, extraordinary care funding, and waitlist funding is how we're trying to be responsive to the committee. But does this fund 100% of reimbursement rate requests that the providers have requested? No. Does it fund 100% of the wait list? No. It's a movement towards those directions, but more modest and conservative than the full request that you've seen in a variety of different forms. So taking that one by one, back to page 138, Mr. Chairman, in terms of the reimbursement rates, with us requesting general funds to increase those rates by what were temporarily supported by ARPA funds in previous years, that represents about $7.7 million annually, which is about 4.8% of current funding. So if you want to think about it in oversimplified Stefan terms, I would see that as an approximate 5% rate increase. Then we have a component of that request in 486 to help us fund these emergency situations that we're seeing more and more of, where acuity is rapidly changing. Additional services are absolutely needed and have been reviewed and approved by our Extraordinary Care Committee, which has executive branch staff, medical providers, physicians, et cetera. In fact, I was on the phone with a family member last week on this exact situation where additional services are absolutely needed and it must go through this process, and there's just a limiting budget factor. Third, Mr. Chairman, again, flipping to page 142, we had proposed approximately $4.7 million of general funds with a corresponding $4.7 million of federal funds to address the wait list. As this committee heard over the interim, we're projecting approximately 450 to 500 people being on the wait list come July 1st of next year. So our request that we made would fund about a quarter of that. The Department of Health's request would fund about a quarter of that wait list in rough numbers. So those three together between page 138 and 142, if you take the total, we're at approximately $31 million total funding. That's with all funding sources, general fund and federal funds. So 31 million total would be about 15.5 million general fund for the biennium. But again, it does not fund 100% of the wait list, but we believe it's a way for us to target those that have been waiting the longest and approaching that 18-month waiting period.
So I had never really envisioned getting rid of the wait list for cost reasons, but this doesn't even get us halfway there. We had talked earlier about level 5, level 6, that those who had been on the wait list the longest would be first up versus those with critical needs. Is that still your?
Mr. Chairman, yes, that would be accurate. And as we discussed in the interim, this is a tough policy area for me, because I totally understand where the committee was coming from on if we can assess people on the wait list at that level 5 or level 6, doesn't that justify that individual or that member needing the service more? I struggle with that for a variety of reasons, because it's not insignificant need when folks are assessed at a level 3 or level 4, and that, extending that wait period because of acuity strikes me as the state or the executive branch picking winners and losers. Whereas it's a bit cleaner for me when we look at just the time that folks are waiting to try to target those wait list reductions every couple of years in a reasonable way. And Chairman Salazar, we agree. I think it's a prudent policy for the state to have some sort of wait list in a program like this, given not only the cost exposure, but various other elements that we know other states have observed, where folks might move to a state that's more favorable on its wait list, et cetera. So it's good to have some sort of natural control on not only cost, but slots that are open. What that ideal point is, 18 months, 12 months, 9 months, 6 months, it's just a really hard policy call and somewhat arbitrary in a way. We do believe that every couple of years it's prudent for the department and the legislature to revisit how long folks are waiting and try to take those waiting the longest off. And I hope you see that here in the request, but you're right.
To us during the interim, we had been talking about a figure of 24 million, as you recall. And then let's talk about the provider rates. Talk to me again about the provider rates.
Mr. Chairman, what we've proposed is to essentially recontinue provider rates from the previous 3-year period that were supported by ARPA funds. Again, we believe that's about a $7.7 million annual rate drop that we saw happen when the ARPA rates expired. So we've proposed bringing those back. It represents just under a 5% rate increase overall in the providers. But again, I want to be clear. The rate rebasing study and the testimony you heard from providers on the rate rebasing, this is not that full package. This is a more modest package that combines, still, if you take these two together, it's $31 million total. But it combines all 3 of those policy areas that we believe, and I think the committee would agree, were the areas we were targeting. Combines provider rates, emergency care funding, and wait list. But it does not do all of them to 100% of what was presented either by the provider group or from the department in terms of the full wait list. With that, Mr. Chairman, happy to elaborate, but we're essentially in a Goldilocks situation. We're trying to find the right balance within the state budgeting and the profile.
I understand that. Well, come January in the markup, I'm sure we'll have public testimony, and I wouldn't be surprised if this number is tweaked. Yes, Representative Pendergraft.
Thank you, Mr. Chairman. Looking at the people that would qualify, and they're on this 18 months, do these type of people tend to become more acute while they're waiting? Or are they fairly stable? In other words, would we maybe be lessening some of the cost by shortening the wait list and catching them earlier?
Mr. Chairman, Representative Pendergraft, it's a mixed bag. There is some of that absolutely where situations are increasing in acuity during a wait period. I don't think that's universal for everybody that's on the wait list. And as we talked about during the interim, folks who are on our waiver wait list in these particular programs, they do qualify for targeted case management. So there is some assistance that is flowing. Is it the full comprehensive benefit or the full waiver service or medical service that comes with this program? No, we try to do our best to navigate to other supports that are available, whether in the Medicaid program or outside of that. But Representative Pendergraft, definitely a mixed bag there.
Other discussion, other questions? Yes, Senator Guru.
Thanks, Mr. Chairman. On the first request, let's see. Let's see. Yeah, 138, I'm sorry. The 21 million, I see that Gov's rec on that is, it seemed like he goes for the request, but then kind of backs out the ARPA. That's the way it appears. And then you look at the other request. I guess, I'm not gonna ask a question I want to ask, but I'll try to go about it a different way. Staying where we are with those rates right now, it sounds like to me, we're not going to be able to hit the mark that we wanted to hit on care for people that are in the program right now. And so I guess for me, the question is, I mean, we want to address the list as well, but adding people from the list on the next request, if we're going with Gov's rec on this one, are we just kind of exacerbating a bit of a problem already? Because we're going to end up shortening the wait list, but we're going to give a half a loaf to the people that are all the way on it. And I'm just wondering if that policy-wise is, you see where I'm going?
Mr. Chairman, Senator Gru, absolutely understand your question. Just as a reminder, folks that come off the wait list come with approximately $30,000 budget onto the supports waiver. So those budgets do drive the availability of reimbursements. Now, the question has been, within the rate structure for providers, is that sufficient enough to continue business? And again, as we discussed at length during the interim, there's a mixed bag there of providers and business models. And in fact, hundreds of Wyoming waiver providers are very small mom and pop shops, and you have other providers that are larger scale, larger staffing models, et cetera, where rate structures are very different in those settings. So again, not answering your question in a great way, but we believe that this sort of multi-pronged investment approach, this mixed bag that is not everything you've seen in a rebasing study, not everything you see on the wait list, gets us in the direction that we need to be going with both provider rates, emergency care, and wait list funding. But it's a difficult question for me to answer on if we don't do, X dollars of financing in this system, will we see massive provider closures or the inability to serve these residents? I don't think that's the case, but you'll certainly hear in markup from providers as you did during the interim. It varies across the provider spectrum on who is more financially healthy than others, who's more on a razor edge with margin or staffing. So I do want to say on record in front of the committee, very sensitive to our provider system's concern, because funding folks off the wait list is part of the way in where we're going. You must have providers, whether that's smaller, individual, lower scale, or larger providers, to serve the clientele that we have in these programs.
We invested a lot of time this summer on this issue. I guess we will decide at the markup. Mr. Co-Chair?
Thank you, Mr. Co-Chair. Director, could you just give us a little more color to the governor's denials and exactly what that impacts on each of these two priorities?
Mr. Chairman, Co-Chairman Bear certainly won't speak for the governor, but we've discussed this the past year at length. And, as you've heard before from other agency heads, this is in balance with the larger enterprise and balancing the budget for all of the requests we made. So I'll certainly speak for myself in relaying those discussions over the past interim in developing this budget. And I know this won't be received well by some potentially even sitting behind me, but I think they'll understand the nature of where it comes from. Over the past 10 years, in multiple rounds, as the subcommittee discussed at length, we've cut the Department of Health budget significantly. In fact, over $100 million general fund in 2017 and the same in 2021. This particular system, with a few exceptions, was largely exempted from those budget reductions, and in fact, in the past 5 or 6 years, has seen some significant growth with rate increases. That's very much part of our discussions in the executive branch, and please believe me when I say that really has nothing to do with the current state of affairs in certain providers' finances, or that we're not sensitive to those, but this has been an area of growth in the department's budget, where you see these two units taken together represents about $330 million of expense in the budget. So Co-Chairman Bear, as waffly of an explanation as that is part of the rationale in balancing this request, which you see here, which is more modest than some of the things you saw during the interim, with some of the other priorities and frankly, some more emergent situations or equally emergent situations that we have in the department in some of the requests that you have here.
Representative Alleman.
Thank you, Mr. Chairman. If I remember right, back in June, there was 365 people on this waiting list. Is that close?
Mr. Chairman, Representative Alleman, it's roughly similar. We had projected July 1st of 2026. I think the last material you've seen was 415 to be on the wait list. We're probably near 450 projected now.
Okay, if we come out, last June we had around 365. This year we're projecting up to 500. We're losing. If we reduce the 500 by 25%, we're losing. Where else in this budget can we come in and help these people and take some fat out of the budget somewhere else?
Mr. Chairman, Representative Alleman, it's a good question, one that we discussed a lot with the subcommittee, and I hope you're not too irritated with my response. You've heard it before. We've looked, especially over the last 10 years with several rounds of budget cuts, to be as lean as possible. 2017, 2021 were painful for our members and our providers across the department. And if there was staffing, administrative bloat, fraud, waste, and abuse that would generate the millions of dollars that could help offset the cost of an appropriation like this, you have my word, we would propose it. What it's come down to is principled policy discussions on, are there things that services, rates, programs that the Department of Health should not cover or should reduce entirely? And I think that's a policymaker decision in the legislature on, should we continue to fund nursing homes at the current rate? Should we continue to fund our senior care at the current rates? Frankly, the general fund at this scale to offset is just not there without reducing those coverages for other populations. So I struggle with that. And it relates back to the stats that you see in our introductory materials, where it's 95+% of our budget is going out the door in those types of reimbursements for other services, for kids, for seniors, et cetera. So I have a hard time saying we can make those reductions and fund a request like this with no impact to other populations. That's extraordinarily difficult to do. Representative Allamand, I apologize for the frustration, but that's the way I see it.
Well, and I can answer that question too for you. Given the time that we committed during the interim, knowing that this was a priority of this committee, it's incumbent on this committee then to make those policy choices and to decide where we want to increase the effort and decrease other efforts. And we'll do that during the markup. Representative Sherwood and then Representative Angelos.
Thank you, Mr. Chairman. I think I just have a technical question in terms of when we get to the markup, and maybe this is for staff. So this is a combined priority number 12. In my notes, I made it 12A and 12B. When we go to vote on this, are we able to separate out the extraordinary care vote from the provider rate vote? Thank you.
Don, Mr. Richards.
Mr. Chairman, Representative Sherwood, you certainly can, and if you wanted to, you can also, and frankly, I would encourage a footnote insertion to specify the preferences of the committee.
Representative Angelos? Anyone else? Okay, guess that's squared away.
For now.
Continue, perhaps.
Mr. Chairman, page 145, Unit 491, Rural Health Transformation. There's one exception request in this unit.
Mr. Chairman, given that we discussed at length the rural health transformation this morning, I'll just mention the technical details here. We have requested the creation of a new unit here, just given the size and scale of what this program could potentially bring in federal funds. So it's Unit 491. As we talked about before, this budget request and narrative was drafted long before the federal guidance came out. So we've provided the legislature and committees with much more detail, including links to our application, to our various budget documents, to our public meetings that we had over the past 3 months. But what this $344 million federal fund request would cover, if we were to get awarded, is what we anticipate would bring us through the rest of this biennium, since it's on a federal year basis. If they award the funding in January, we're essentially still in the 25-26 biennium in the state. So this would be the remainder of this biennium plus the 27-28 biennium. But we're more than happy, as is obvious, to brief this committee and the legislature as we get more detail from the federal government later this month and going into 2026.
Questions? Mr. Co-Chair.
Thank you, Mr. Co-Chair. So if everything went smoothly, best case scenario, which probably won't happen with the federal government, but what would be the earliest that you would see an award come?
Mr. Chairman, Co-Chairman Barrett's good question. So we know by the law, by HR 1, they have to make award decisions by the end of this calendar year, so end of December. How that translates to the mechanics of the federal government providing that award, actually sending the money, we don't know that yet. Could it be at the same time? Yes, in which case we would initiate the process for that, both in terms of potential B11 or, and discussion with this committee and the legislature in January. It could also be that the award happens in terms of what the federal government has decided will be awarded, and the mechanics of that transfer go into January, February, even March of 2026. We just don't know yet. I'm optimistic in the next 1 to 3 weeks we'll have that level of detail from the federal government. As I mentioned, we just saw this morning before heading over here a list of questions on various budget-related elements from CMS, from the federal government, for us to respond to by the end of this week. So that process has started in terms of discussions and negotiations.
Please continue.
Mr. Chairman, that completes the Healthcare Financing Division. We'll be moving into the Public Health Division.
Representative Pendergraft?
Thank you, Mr. Chairman. Actually, it's a comment. I've been sitting here wondering whether or not it would be appropriate to comment, but I think it is in this case. Basically what started the subcommittee was I had asked the same question of you. And I've spent, as you well know, a couple of months looking very intently into what the Department of Health does. I have learned a lot. I think there are some places where we can find some money, but I think those things are more policy decisions, which are better coming from this committee than from a department that has been tasked to accomplish certain things. My work is not yet finished. We'll be discussing that more. And for those of you in the public who have been following this, again, I will reiterate, we're trying to do it as judiciously and as carefully as we can, and try to afford the best care for the people that we can get. And I just want to take a moment and thank you guys for what you do. You have been very open. You have been very willing to provide any information which the subcommittee has looked for, and I thank you for that.
Please continue.
Mr. Chairman, page 150 is the first unit in the Public Health Division. It's Unit 501, Public Health Division Administration. There is no exception request in that unit. Moving to page 154, Unit 502, Public Health Preparedness. There is no exception request in that unit. Page 158, Unit 503, Emergency Medical Services and Hospital Preparedness. There is no exception request in that unit. Moving to page 163, Unit 510, Rural and Frontier Health. There are no exception requests in this unit. And then page 167, Unit 522, Immunization. There is one exception request in this unit, the top of page 168.
Mr. Chairman, page 168, this is priority number 32. We would like to eliminate 7 at-will employee contractor AWAC positions from this unit. As you see in the description there, there's 7 positions here that were approved in the 23-24 budget with all federal funds from the COVID-19 response. That response has obviously ended. We haven't had these positions filled for a while. So as we promised both the governor, A&I, and this body back in those days that we would not use positions beyond the pandemic period. You'll see 2 requests similar here. This is one of them, to eliminate those positions.
Continue.
Mr. Chairman, we are on page 172, Unit 523, Maternal and Child Services. There are no exception requests in this unit. Moving to page 177, Unit 524, Nurse Home Visitation. There are no exception requests in this unit. And then moving on to page 180, Unit 525, Women, Infants, and Children, or the WIC unit. There are 2 exception requests in this unit. The first one on the top of page 181.
Mr. Chairman, priority 17 on page 181, very similar to what I just mentioned previously. These are positions that have since transitioned to county-based positions, so we are requesting to eliminate 6 AWAC positions in Unit 525.
The second exception.
Let me stop you there. Senator Guru.
Thank you. Just one question. Back on 180, on the Gov's rec, and he has this a number of times through this one about not, money should revert, that would normally revert, wouldn't be spent without B11, and all that verbiage. You're all okay with that? I think I understand what the governor's trying to do. He's trying to get a little more transparency in all this. So that's not any issue. Okay, thank you. Thank you, Mr. Chairman. I got it.
Mr. Chairman, on bottom of page 181, this is a similar request that we made last year in the same unit in Women, Infants, and Children, or WIC. We had requested last year to convert 12 part-time positions to full-time positions. No general fund needed to do that. Just to remind you of our discussion last year, these are positions we need in these field offices for our clients to work full-time. We're authorized for part-time, so this helps us avoid unnecessary overtime, things of that nature. I believe this committee supported this request, or check my memory there, I know both chambers discussed and ultimately supported it in the floor budgets, but we've brought this back for consideration. Technical detail doesn't require general fund, but these positions would be much more beneficial as full-time than part-time.
Any questions? Okay, continue.
Mr. Chairman, page 189, Unit 526, Public Health Nursing. There is one exception request in this unit. It is on the top of page 191.
Mr. Chairman, a bit of background here. A couple of years ago, the legislature passed a bill that was codified into Title 35-1-243F. This requires that anytime the executive branch has any compensation adjustments or salary increases for nursing staff, as happened a couple of years ago with state employee compensation, that we are required to bring a like ask for essentially the independent county public health nursing offices that operate. Counties have an option to be completely independent, be a hybrid county-run public health nursing office, or be fully run by the state of Wyoming. There are 5 independent county public health nursing offices, and again, per the statute, this is one of those requests you saw in the department summary materials that is mandatory per statute. On a biennial basis, it's $203,000 of general fund that would essentially up our reimbursements to those independent counties to pay their public health staff, their county nurses. With that, Mr. Chairman, happy to answer any questions.
Any questions? I'm looking for a break here to stay on schedule, so how are we here?
Mr. Chairman, we are almost finished with the Public Health Division.
Okay, continue.
Mr. Chairman, page 194, Unit 531, Cancer Screening, there is no exception request. Page 199, Unit 532, Public Health Laboratory, there is one exception request. It is on the top of page 201.
Mr. Chairman, again, similar to a discussion we had last year with this committee, making a request for our public health laboratory. This is the only state public health laboratory. While you're in town during hearings, would encourage you to contact Dr. Reed and our staff if you ever want to tour it. It's an impressive place. We occupy that building also with DCI and the DCI Crime Lab. But we've seen a significant increase in due to inflation over the past 5 years in the cost of our service agreements and equipment for those service agreements for our equipment that we previously in the past 5 years were able, like in many other areas of the department, to support with temporary one-time federal funds. Our demand from law enforcement, from hospitals, from the customers we serve through the public health laboratory for chemical testing, urinalysis, genetic testing for newborns, et cetera. That demand has not waned. And frankly, as Mr. McVicker can describe here, we've just seen inordinate growth in the cost of some of this equipment and service. So we put this in front of the legislature for consideration, and happy to let Eric add any color commentary that he has. But as I mentioned in my introductory comments, we also have Dr. Harris and Dr. Reed here, should you have more specific questions.
Mr. Chairman, just some insights on this request. I think there's two pieces here. As the director said, we had some increased federal authority through the COVID and ramped up what we were doing at the lab. That money has now gone away, so we've seen kind of a federal fiscal cliff that we're looking at. But on the other hand, similar to construction, some of the software maintenance agreements and things are just skyrocketing in cost. Some of our agreements have gone up 100% over the last 3 years. So with the combination of those things, we bring this request in the hopes that we can continue to provide the same services that we're providing today at the laboratory.
Director Hibbert?
Thank you, Mr. Chairman. On page 202, I would like to request a correction to the table. Remember, tables are important because you're going to take action on the tables. The $1,820,623 that's in the maintenance agreement 292 should reflect the governor's recommendation and also the agency's request on page 201. The agency requested $607,227 in object 240. So we'd like to have that move from 292 to 240. Then the agency's request is actionable to the table, and so is the governor's recommendation. There is no impact to the general fund profile.
Thank you for that. Appreciate it. Representative Pendergraft and then Representative Sherwood.
Thank you, Mr. Chairman. This is yet another example of, I guess I would call it the tail wagging the dog. This legislature did not approve a particular action, but it was mandated by the federal through the ARPA increase of funds. And now we're confronted with, now that those funds are no longer there, are we going to continue to support that level of funding that we never authorized in the beginning? What I'm asking for is there a way to go throughout the agency and give us a summary of these examples so that we know what the state is supporting now that the ARPA funds have dried up?
Mr. Chairman, Representative Pendergraft, happy to do that. And your point's well taken. I'll mention just as a little bit of commentary on your statement. You're absolutely right. There were funds that flowed in. Public Health Lab is no exception. We did ramp up heavily during the pandemic to provide testing and many other services that have since discontinued. But there were other areas that those funds supported also that, for lack of a better phrase, I would say masked demand that was already there. And we see that with our senior centers as well. So we have expiring federal funds from the pandemic era that were supporting care in our senior centers where, for nutrition, congregate meals, home delivered meals, et cetera, that yes, absolutely, the financing ramped up during the pandemic, but that demand was not necessarily pandemic related and didn't go away. We were just able to shield that by an advent of federal funds for a couple of years. And I think the lab in a few areas is very similar. So if you see in the description, we were able during the pandemic to ramp up our courier services, where for hospitals and other providers that we serve with laboratory needs, we courier their specimens to us. To your point, Representative Pendergraft, is that something that we should do? It's not pandemic related. We used pandemic funds prior, and there were pandemic elements to that with COVID-19 samples. But across the board, it is a service and an efficiency for the system that we provide. So we want to be transparent here and say, this is a request that I'm making to continue that level of service to the demand we see. But we would essentially implement a reduction in that service, or reduce our courier services and some of the other items you see there. But we wanted to bring it for consideration because it is on the tail end of expiring federal funds that were related to, the pandemic, but we're supporting areas that can be beneficial to Wyoming and thought it prudent to have that discussion.
Well, I don't think anyone is denying the need.
Right.
but the point is that it's hard to transition off free money. A previous appropriations committee could have easily used general funds and made it straight and clear. And now, frankly, we're holding the bag with this new appropriations committee because it was easy to use that free money. Representative Sherwood and, well, do you have a follow-up? Let's do the, okay.
Thank you for those comments. I think it's totally appropriate in providing this data that I've asked for to have a column for comments and justify the expense.
Yeah.
Thank you, Mr. Chairman. With the lens of trying to save general funds, I do have a question about the Agency Fund 412. That's on page 200. A few questions. One, when was the last time fees were adjusted? My other question is, could we consider using this fund to support a portion of this exception request, whether that's one time something in terms of allowable expenses? I will have a follow-up question on another page that relates to this, but I'll stop there. Thank you.
Mr. Chairman, Representative Sherwood, the general answer to your question is yes, we could consider tapping that fund. I'll look to our CFO and our lab staff to, maybe weigh in if we get into the details on that. I would also like to mention that this is not something we're bringing as a request to this committee because we're just now reacting to this fiscal cliff that we're seeing with these expiring federal funds. We've been planning for this for a year or two, and in fact, Mr. Reed and Dr. Harris and staff have prepared a plan for how to increase revenue in the lab through looking at new fee structures, new rule structure in our administrative rules to make sure that we're doing our due diligence by not only providing the service that to the points that were made earlier, I think there's a demonstrated need there, but also collecting reasonable fees for that service. So I think it's an all of the above approach, Representative Sherwood. Eric, any detail to add on the fund specifically?
Mr. Chairman and Representative Sherwood, yes, with those funds, I'll just echo what he said. Those funds could be used. But I would like to defer to Dr. Reed. I know he has a microphone with him because he has been doing a rate study or a fee study just to kind of see where we are. So I'd like him to comment on that if he could.
Yeah, no problem. Dr. Reed, Administrator for the Wyoming Public Health Laboratory. Mr. Chairman, Representative Sherwood, we've been working on a fee study for the last about a year and a half with our director's office, specifically with our Deputy Director, Franz Fuchs. Through that study, what we've done is we've looked at the fee structure that other states are using, that private companies are using, and we have modeled out what it would look like if we were to go ahead and raise our fees. And so what we've done with this exception request is we've actually combined both of those models to say we will need to raise our fees, and we will likely need to significantly raise our fees over the next few years. So as Director Johansson suggested, we right now will need to change our rules in order to raise the fees to what we deem the market can handle, and then look towards stepwise doing that for our customers. I do want to point out that the main customers that we have that are paying fees right now are other state agencies like the Department of Family Services, all of our law enforcement partners, and then our diagnostics partners as well. So any type of fee change will directly impact them, and so we want to make sure that we're taking them into account while we do these studies, and we are actively looking to seek feedback from them right now as to what their budgets will be able to accommodate as well. Thank you.
Please.
Thank you so much for being proactive in this area. Super appreciative of that. In terms of timeline, so we're getting feedback from those who are going to be impacted by the fee changes. Great. There'll be rulemaking process on that. Great. What is the maybe gap analysis here in terms of when those rates go into place versus when you're needing these funds? Again, I'm just trying to hone in on, is there a sweet spot that we could say, $500,000 of this request could come from this Fund 412 without messing up the process that you guys are in right now? Thank you so much.
Mr. Chairman, Representative Sherwood, it's a really good question, and I think whatever the committee and ultimately the legislature's will is on this request, it will be adjusted by what that inevitable change looks like in our revenue collections through rates. So as you know, in Department of Health, we're pretty transparent in bringing what our projected reversions are. And if we offset a request like this through an additional $500,000 of revenue collection from fees, as an example, we would correct that in the supplemental. Timing is tricky, similar to the Rural Health Transformation Fund, where we're not exactly sure what our law enforcement, hospital, other state agency partners could support right now. So we want to be delicate in that, where we don't raise fees and then you guys see a bunch of emergency requests from other agencies because another state agency just decided to raid their budgets. So that's in process right now. And as we go forward, again, I wanted to bring this in isolation so we didn't confuse or under project or over project on either side of that ledger. But we would certainly adjust going forward by just what the public health laboratory needs to continue the level of service.
Okay, co-chair?
Thank you, Mr. Co-Chairman. I want to kind of address something that my colleague to the far left of this dais, I'll make that clear, has pointed out, and that is your cooperation with ETS. You made the comment, the software agreements are skyrocketing. How closely are you working with ETS on this issue?
Mr. Chairman, I'll let Eric or Joe weigh in here. We work very closely with ETS, but it's important to remember in certain areas of the department, we fall outside of what the OCIO manages in terms of systems or softwares that are either hosted on state servers or not. So both in terms of our public health or our Medicaid technology, in many cases, we're outside of that ETS purview, but still in those agreements, we're working hand in hand with the OCIO and ETS on those procurements. Certainly let Eric or Joe weigh in on for the Public Health Laboratory on ETS involvement in our systems.
Joe Reed, Administrator for the Wyoming Public Health Laboratory. Co-Chairman Bear, to answer your question, we're working directly with ETS on assessing our systems and ensuring that they are compliant with the Office of Civil Rights requirements for us for HIPAA, as well as the state's requirements for the retaining of data for set amounts of times, for example, for state archives. We've transitioned many of our systems over the past few years to enterprise-type systems that have helped us. And we have also begun transitioning some of the legacy systems that we had that may have been 20-plus years old, including some of our databases that supported our breath alcohol program, to new systems that can, number one, better serve our constituents. So we have over 1,300 operators in our communities of those breath alcohol instruments. And we believe these new systems will help them to be able to track their data and track usage of instruments, for example. All of that's being done with a great partnership with ETS in order to make sure that we're updating those systems in a compliant manner. Thank you.
Okay, so I need to get on schedule here. How much do you have left?
We have one more request in public
Go
health.
ahead.
Mr. Chairman, page 204, Unit 534, communicable disease, there is no exception request.
Representative Sherwood.
Thank you. This is my follow-up question. So here in Unit 534, communicable diseases, there is a standard budget request, 577,244 from special revenue, so that same account that I was referencing, account 412. But we're projecting in the table $1.1 million. So and I guess I'm looking for correction, like where am I getting this kind of wrong? It looks like there's a excess request reflected through Fund 412 of $572,800. And I'm just, again, thinking about, is there an opportunity to save general funds by moving this around between this unit and then the public health lab? And if that was clear as mud, I can talk to you in the hallway. Thank you.
Mr. Chairman, Representative Sherwood, yeah, this Fund 412 is used by multiple different units. So each of those units, those dollar amounts are available for those particular units, but we don't have like flex authority to move that money around between those different units. So it's generally used that way. Does that answer your question?
All right, thank you. So I'm on page 205 for the committee. So we're in unit 534. So if you go to that expenditures unit 534 on the table, and you look at the estimated expenditures being 1.1 million, but in the standard budget request, it's 577,244. So I guess if you can just speak to, yeah, the difference there. Thank you for educating me. Thank you.
Mr. Chairman, we'll get you an updated table that reflects that.
Thank you. Anything else?
Mr. Chairman, we can just move to page 213. It is our last exception request in Public Health Division, and this is really just a net to zero. So this is in injury and chronic disease prevention. It's where our 988 suicide prevention funding was originally appropriated. We have moved that 988 system over into our behavioral health division, so you'll see a negative 400,000 to remove the remaining funds from public health, and a positive 400,000 in subsequent unit discussion that we'll have in behavioral health, just a net to zero cleanup where the budget authority is.
Any questions? Any questions? Okay, with that, yes,
Mr. Chairman?
Director Hibbert.
Just one last house cleaning item. We use the Department of Health, and thank you, Department of Health, for facilitating this, to manage the tobacco funding. So they have a request in here for an effective immediate in 2 units for tobacco money. The tobacco money is used in multiple agencies: Department of Corrections, Department of Health, Department of Family Services, the AG's office. So please don't take a reduction here, because it would only reflect against the Department of Health as only helping us with balancing the tobacco funds from one biennium to another. So we talked about the opioid funds yesterday, about how there was a higher amount of money in the past and there's a lower amount in the future. The AG's office is typically conservative on their estimates. They do the estimates for opioid and they do the estimates for tobacco. We're simply adjusting those estimates to actual with money that we actually collected over the conservative estimate of the Attorney General's office. But this is for the entire enterprise, not simply Department of Health. So thank you, Department of Health, for allowing us to use you as this instrument.
Okay, anything else? Okay, well, thank you. With that, we will adjourn until 12:20. 1:20.